nearly very less frequently encountered in home dialysis patients. In all these factors, they are more relevant, all of them are relevant, but the most relevant is better quality of life and better survival for home dialysis patients. And this is a success story. This is what we want to aim, and this is what we want to own as a community of nephrology internationally, that a patient who has been on dialysis for 48 years is still ambulatory, is still having a good quality of life, of course with limitations, but all therapies, if they are optimized, that can lead to a much, much, much better outcome. I feel all dialysis modalities are good. If they are optimized, if they are individualized, all patients should be individualized in nephrology-based care. This is the conclusion. Home dialysis, there is improvement in quality indicators. There is improvement in hospital admissions. In-hospital admission course is better. We encourage home dialysis to be actively considered as a dialysis modality, but this is the discussion that we are starting in Saudi Arabia. Why not for the young patients? Why not for the patients who are mobile? Why not for the patients who don't have any comorbidities? Why to wait for the patient to develop comorbidities for them to be eligible to receive a dialysis therapy that might be having possibly better outcomes? And for this, we believe that multi-center collaboration is always needed and is always welcome from our side also. And I would like to thank all our respected colleagues who spared this time to listen to this talk. And if there are any questions, I am all yours.
Thank you, Dr. Bilal, for such an impactful and insightful talk. I have 3 questions. Do you think so that this project is reproducible in Pakistan? हम कर सकते हैं? आपका, sir, let me. Have you done any homework, like how much it would cost us to build the program from scratch? Equipment, support service, सारा कुछ के ऐसे में तो definitely you have MOH और बाकी सारे departments मिलके काम कर रहे हैं. और जैसा आपने कहा कि your roots are from Pakistan and it seems like आप help करना चाह रहे हैं. तो how would we can collaborate and how you can help us to start a home hemo program, let's suppose for next 4 or 5 years?
I believe that it all depends upon our vision of the patient's life. Like how we deal with a patient who is on dialysis. Is he still an entity which is important for us? The quality of years of his life, is it important than the resources at immediate setup or not? Like when we calculated the cost effectiveness and we presented our work in the VBHC awards in 2024 and we won this study all over the world, that there is a cost effectiveness when we see 2 years of reduced hospital admissions, reduced burden of consultation, reduced estimated length of stay, reduced complicated vascular access, IR procedures, reduced number of resources, human resources that were needed to stabilize an intermittent dialysis patient on home dialysis, then of course it is superior. And of course, if after a session of dialysis, my patient just walks out of the bed and he's going to work again, and he can take his family out, that is a big achievement for me. I believe it can be done. But at the early startup, of course, definitely the cost, we will see the cost to be more. But when we see futuristically the next 5 years of cost of this patient and other factors, I believe that home dialysis can be very beneficial.
Sir, I would like to rephrase my question. Like, if you have to start a home hemo program in Pindi, Islamabad, how would you initiate?
First thing first, I would like to see the families who are interested to induct themselves in the home dialysis program. This is the first thing. Secondly, of course, we can present our findings to the administration and to the people who are basically on the helm of affairs as far as the finances are concerned. And we can definitely collaborate with the companies who can come and who can provide these services.
Thank you. There is a question from the panel as well. The data you presented is appreciable. However, it is a paradox to see that old and frail patients who have many comorbid conditions are doing better than those who are younger and have better facilities.
Yes, sir.
So this conclusion is based on what? Either you are not providing good in-center dialysis, you are providing better dialysis at home. You are dialyzing them 4 times in a better environment with lot of nursing care, where in-center you are not providing that level of care. And that's how you explain the discrepancy. Simple, the change of place is responsible, or you are offering more dialysis to the in-home patient compared to in-center patient?
Sir, sometimes
Excuse me,
a limited.
may I add a little bit to this question? That the selection of patients for home hemodialysis and in-center hemodialysis may be different, because the patients who are selected for home hemodialysis, they must be more stable hemodynamically, they must be having more static renal parameters, and no intradialytic hypotension and all those complications must not be reported. And the second, like Dr. Saab has highlighted, that maybe this can be due to difference in the dialysis therapy, difference in the dialysis doses that you provide to these patients who are given home dialysis and in-center dialysis. So the discrepancy in the data, could that be related to these factors?
So ma'am, I would like to elaborate. Thank you so much for these questions. Sometimes a limitation is a blessing also. That when a patient is immobile or he is bedbound, he is not expected to be non-compliant to dietary advice, and he is more compliant to the medication because there is a healthcare provider basically arranged by the family to give the medication. So probably this can tell us the compliance of the dialysis therapy and the compliance of the medication and the compliance to the diet that has been prescribed to them, due to which the hyperkalemia and calcium phosphate products and other things are there. And definitely, ma'am, I agree with you that the dialysis modality itself with less inflammatory response with home dialysis can be a reason that erythropoietin resistance is not there. And erythropoietin resistance is also not there because the PTH targets are met. The third thing is that this is the paradox that I would like to highlight again, that when we chose home hemodialysis patient, it was not that we chose them, it was an obligation, because the patients were not able to travel to come to the dialysis, so most of them were bedbound with higher burden of comorbidities. Then sir, he asked, he gave a comment that maybe it is the type of service that has been provided, maybe it's a better staff. I agree to that, that it's a one-by-one staff to the patient. It can have an impact, but maybe there is a component of the dialysis modality also that may be having an impact.
This, I thank you very much. This again highlight the question in your center that your inpatient dialysis is probably not sufficient and it is probably incompetent. It is not providing the quality of care to the younger patients. So that needs to be looked into very thoroughly, really.
Thank you, Dr.
Yes,
Mohsen. Thank you.
Okay. Thank you so much.
Thank you.
Thank you, Dr. Bilal, for highlighting how innovation paired with system-level planning can empower patients beyond hospital walls. A reminder to the audience, technology does not replace care, it amplifies it when used wisely. Coming to the next topic, protein energy malnutrition remains a silent predictor of poor outcomes in dialysis patients, often underestimated and under-addressed. As Hippocrates said, and I quote, "Let food be the medicine." This talk will reconnect us with the fundamental principle. I invite Dr. Tasnuva Sara Kashem, who is an assistant professor at Kidney Foundation Hospital and Research Institution, Bangladesh, to discuss protein energy malnutrition in hemodialysis patients.
Assalamu alaikum. My name is Dr. Tasnuva Sara Kashem. I'm Associate Professor of Nephrology at Kidney Foundation Hospital. Thank you for the invitation. I'm really glad that I came to Islamabad, Pakistan, and it's beautiful from what I've seen. This is the hospital that I work in, Kidney Foundation. We are an ISN graduated center. And this is Bangladesh, which is also very beautiful, especially in winter. So I welcome all of you to Bangladesh. So my topic today is protein energy malnutrition. And I'm talking about it today because we did like a study with Wayne State University about 7 years ago and found that it is quite common in our hemodialysis patient. It is underreported because of the criteria that is stated. And if we do come out from the criteria, I think we're going to find more about it. So what is protein energy malnutrition? Well, malnutrition, as defined, people think it's about deficiencies, but it's not about deficiencies. It can be excess food. So the junk food that we're having could be very high in calorie, but very less in nutrient. So, so excess food can be also cause of malnutrition. And the imbalances, so not having the right food. So you're having the right calorie, but the balance of protein, carbohydrate, and the nutrients are not in balance, can also lead to malnutrition. Protein energy malnutrition is exactly what it says. So it's depletion of protein and energy. So the patients are lacking protein, adequate protein, and adequate energy, and that is what's leading to malnutrition. And our CKD patients, more than the dialysis patients, are at risk, because we can, to some extent, replace the protein in our dialysis patient, but we restrict our CKD patients, and that puts them at a higher risk of protein energy malnutrition. So what happens in protein energy malnutrition is we have muscle loss, fat loss, low protein, and low energy, and then there's increased catabolism, and altogether they're in a state that's putting them at high risk. And why is it important? So the prevalence is from the International Society of Renal Nutrition and Metabolism. It says about 42.7%, but it ranges from 20 to 70% across the globe, depending on the economy and the region. Hemodialysis patient, as you can see, is 28 to 54%. And in CKD patient, it's 11 to 54%. So these are non-dialysis patients. And as the stage progresses, the severity of protein energy malnutrition increases. It is important because it increases mortality. So protein energy malnutrition puts our already high-risk dialysis patients at even higher risk of death. They have increased hospitalization and poor quality of life. And what are the drivers for it? So we lose about 10 to 12 grams of amino acid during dialysis. Our patients are already, they have chronic inflammation, which puts them at risk of muscle breakdown. They're anorexic, uremic, they have poor appetite. We're telling them to take more protein, but they don't want to because they have a very poor appetite. And then the metabolic acidosis, again, contributes to muscle lysis. So this, again, also in CKD. So we have poor protein synthesis, more protein degradation, more muscle wasting. So again, that leads to protein energy malnutrition. Oops. And they're all interconnected. So when you have chronic inflammation due to infection, you are at risk of protein energy malnutrition. But then when you have protein energy malnutrition, protein energy wasting are interchangeably used. You are at risk of infection as well. Again, you're at risk of cardiovascular disease. Patients are frail and depressed, and again, protein energy malnutrition can contribute to it. So the International Society of Renal Nutrition and Metabolism has set criteria. They've set 4 criteria, and we have to meet 3 of them in order to diagnose protein energy malnutrition. And I find it very difficult in Bangladesh to meet all these criteria because our patients are poor. They cannot do all the biochemical markers, but we can do the nutritional assessment, and we've done some assessment based on that. They don't want to do serum albumin. It's not commonly done, but the serum albumin needs to be less than 3.8. Low serum prealbumin is probably done as a research in South Asia. It's not done in Bangladesh. I don't know about Pakistan. Cholesterol is commonly done, so we can do that. Low body mass index, this is easily done. So we've got a nutritionist in-house who can actually go and do the BMI of this patient. So if it's less than 20 in South Asia, 23 is more for Western country. It's considered low body mass. If you have unintentional non-edematous, so the dry weight loss less than 5% over 3 months and more than 10% over 6 months, and you have a total less fat less than 10%. So you need instrument to measure the body fat as well. So if you're in a resource limited setting and you don't have this instrument, you'll have to depend on the mid-arm circumference and things like that to measure the body fat. So loss of muscle, so you can do anthropometry. Again, this is something you can do by just measurement, the mid-arm circumference. And there's a very good indicator, which is the indirect indicator of poor nutrition, which is creatinine. If you see a dialysis patient in our country with low creatinine, don't think their renal function is improving. It's probably because they're very, very malnourished and they cannot generate that creatinine. Again, DEXA scan is expensive, but you can use it if you do have the resource to look at the lean mass index. And it is gold standard. You can use CT scan, again, to look for fat and skeletal muscle. But again, you need to have the resource. It's not going to be, we can do this in our center, but not in the peripheries. And low dietary intake. So they don't take adequate calories. So low protein intake. So dialysis patients should take at least 1 gram per kilo per day, which is for a 60 kg is like 60 gram. And if you think about food, they're very anorexic. To achieve that is very difficult without supplements. And energy, they need at least 30 to 35 kilocalorie to achieve the intake. Again, they're depressed, there are financial constraints, and then they have limited access to nutritionists. Not all hospitals have an in-house dietitian like we do, and she does go around to the patients individually to assess them. It made a big difference in our center, and I highly recommend having one dietitian in-house who's just going to be focused on nutrition. So like I said, the energy intake is 30 to 35 calories, which is quite a lot, and it is quite difficult if you see for them to achieve for someone who doesn't want to eat. And the protein requirement, 1 gram per kg per body weight. So how do we achieve that? Well, the current guideline says that adequate protein and energy intake, and then high quality protein. What is high quality protein? High quality protein is basically where you have protein to phosphate ratio adjusted. So where you have less than 10 milligram of phosphate per gram of protein. 1 gram to milligram ratio. And there are very limited food that you can achieve with that. So like egg white, unprocessed meat, that can give you that. But then we said, oh, their phosphate's going to go up. So are we concerned about their phosphate? Are we concerned about their protein intake? So what do? So we can give them phosphate binders and tell them to eat more and choose food that can adjust the phosphate to protein ratio. And we have to give them supplements in order to achieve what they have said to combat protein energy malnutrition. So this is about phosphate to protein ratio that I have said. So natural phosphates, that comes from plant protein, the natural proteins, have low phosphate and they're good phosphate, but the protein content of them is very less. You need to have big amounts of them. The one from meat, the phosphate is less absorbed, but then their phosphate content is higher compared to the plant proteins. And then there are hidden phosphate in the processed food, which a lot of people think, oh, it's quick energy, good calorie intake, but at the same time, the balance is completely wrong in this processed food. You can get up to 14.6 milligram per gram of phosphate in this processed foods. So these are just some examples of good protein. So febrile egg white is very good. Freshwater fish is very good. Unprocessed chicken and beef are good. White rice, you can see it's 17.1 milligram per gram of phosphate which us Bengalis really are, we count on. We're very, very big fan of white rice. So this is a slide just showing the average protein content in food. And you can see that 28 gram of protein, if someone's having for one meal, is only giving you 6 to 8 gram of protein. So if you're having like 100 gram of nuts, dried beans, you're only getting 7 to 10 gram of protein in it. So you need to have a lot of them to achieve your intake. And this is just an example of showing, so this is 60 gram of fish. It's very big. If I tell my patient you need to have like at least 3, 4 of them during the day, they're not going to have it. They're only getting 15 gram of protein from 60 gram of fish. From chicken, they're getting 30 grams of chicken is only giving them 78 grams of proteins. So these are plant proteins. Again, they're good, but then the protein content is not very much. So vegetable, we tell them to have lots of vegetable because they're good for you, they're good fiber. Yes, the protein content is not great, but then it's good nutrition-wise, other nutrition. So then, because we are not achieving that, we recommend them to have supplements. And that is where we are restricted, because supplements are expensive. If supplements doesn't do the job, then you're supposed to go into interdialytic parenteral nutrition. We sometimes jump to that because it's cheaper than oral nutrition. And the last but not in ICU or in critical setting, you can go for parenteral nutrition, but it's not very commonly used in Bangladesh. So these are some of the dialysis patients of Kidney Foundation. We did a study, like I said, in 2018, and it was published in the Nutrient Journal in 2022, of 133 patients, of them 18% suffered protein energy malnutrition, but we think this is underreported because we did not have blood tests in all of the patients done. So not all of them had albumin and not all of them met that criteria. So what did they do? They did the biochemical markers, assessed the body mass index, measured the mid-arm circumference, and the 24-hour recall, and then the malnutrition inflammation score, which is also very good at assessing malnutrition. There are some ongoing studies that's going on, which is done by our clinical dietitian, Tazreen Yusuf, and her students. She's trained about 162 students since we've started the nutrition diploma course in Kidney Foundation. And this is her students who goes around. So she's the lead, but these students go around the dialysis unit, collect the data, come back to her. So she's one person looking after 600 patients is a lot. So her students help them a lot. So currently there are about 602 scheduled hemodialysis patients. Of them, 160 are on thrice-weekly dialysis and 442 on twice-weekly dialysis. We have 2 patients, it varies, on 4-weekly dialysis session, and about 70 PD patients. Out of the 602, 254 patients were assessed for malnutrition, very crudely. And 34 of them, 13% patients, are identified as malnourished with low BMI, muscle wasting, and poor nutrition intake, and loss of stamina. So they don't have any, they report that we have no energy. And these are some of the cases. These are real cases with patients' permission that I'm sharing. This is a child with 14-year-old with only BMI of 16. So we've told them that they need protein supplements. They can't buy it, so they're not meeting the requirement. So Tazreen has given them fortified food, so alternative food that will give them the best alternative that you can get to achieve the protein and energy requirement to combat this. This is another lady with BMI of only 15. Again, her finances are, she's lacking 42 grams of protein daily, which she can achieve with an oral supplement, but she cannot afford it. And then again, this is another patient who's underweight, and it's the same problem that we're facing with them. So what should we do? Yes, nutritional supplement, very easy to say, but hard to get in this group. Especially where I work, it's a non-profit hospital, so we have middle to low-income patients. They're not very poor, they're middle class, but it is a big burden on them. Food fortification can be easy if we know what to tell them. Eating frequently is a very good advice. So eating every 2 to 3 hours, having little snacks 2 to 3 times a day, and not missing any meals. Make sure you have your breakfast, lunch, dinner, and not to drink too much water between meals. Exercise, fresh air, going out, all these needs connection with the patient, and you need one dedicated or more person to actually get on with it. Thank you. So this is our team. We do have a good team. We're trying to build another team of nutrition. This is my sir, Professor Harun Rashid, and we're very proud that we work very good as a team. And we have another team from Royal London, which involves Professor Magdi Yaqub, Katie Bennett-Richards, and Professor Stanley Fan. They come every year. They see our progress. And I think over the 7 years since I went back to Bangladesh from Royal London, They have helped us progress a lot, and we really appreciate it with all the support that we've got from them. This is Dhaka at night. It's beautiful. You're more than welcome to come, and we'll show you around. I've just shared the cost, because time is allowing, of the Pentasure. So it's about $10 to $15 of Pentasure. So our DLS, which is 7 grams of protein per feed. And they need at least 4 to 5 feeds, which is 6 feeds. And it is costly for them. I don't know whether you have cheaper protein supplements in Pakistan. If you do, please share with us. And if you do have any, so we actually rely on this. This is the dietary advice. So if you're having vegetable oils, have ghee. I know it sounds like it's going to increase the cholesterol, but they're assessed. They're so malnourished. They're so malnourished that we can let them have a little bit of calorie. And then we have to balance it for the phosphate content as well. So most of them are on phosphate binders, but phosphate binders are also not cheap. So thank you very much.
Your patient you have on dialysis, a majority are on twice-a-week dialysis.
That's right.
And I think probably 1/3 of them are on thrice-a-week dialysis.
That's right.
This is your malnutrition assessment on all the parameters. Do you find any difference between the twice-week dialysis and thrice-week dialysis? Based on the assumption that they are more adequately dialyzed and then less uremic toxin and better appetite?
Thank you for this question. We're actually looking at it. We actually did a study last year looking at these patients, but the nutritional assessment was not adequate because we didn't have all the parameters marked. But they definitely have a better survival in thrice-weekly compared to twice-weekly patients. But yeah, nutritional assessment, like the study is ongoing, and we will report the study once we complete it. But the interim analysis does show that they do have a better nutritional state than the twice-weekly. Thank you.
Any other question? Okay then, thank you very much.
Thank you. Thank you for that clinically grounded and practical overview. A timely reminder that dialysis adequacy is not measured by numbers alone, but by patient resilience and nutrition. Now coming to the other talk, dialysis frequency is not merely a prescription decision. It reflects resource availability, patient physiology, and ethical balance. This presentation brings local data into global dialogue. I'll invite Dr. Mufti Bali, who is a consultant physician and nephrologist working at MMC General Hospital. He will take us through Pakistani perspective on twice-weekly hemodialysis. Thank you, sir.
So, very good morning to all. I am Dr. Baligh, and I'm just a student of nephrology, and I find it very difficult to comment on myself because there's this common practice in our population of dialyzing our patients twice a week as compared to the standard guidelines, 3 sessions a week, 4 hours per session, single pool KT by V prescribed 1.4 and delivered to a minimum of 1.2, and standard weekly KT by V, which is a sum of KT by Vs of individual hemodialysis sessions along with the residual renal function. So if you sum it up, the minimum has to be 2.1 per week, right? So I'm going to talk on regarding the pointer's not working. Right, so I'm going to talk on about the evidence that has been published regarding twice-weekly hemodialysis. And we note since this is not a standard practice, we can only find the bulk of evidence commenting on twice-weekly hemodialysis in patients who are actually undergoing incremental hemodialysis, which is slightly different than what we are doing, right? So incremental hemodialysis is basically for the patients who have got significantly preserved residual renal function. And then you start them on dialysis at a lower level, maybe once a week or twice a week. And then we'll see those studies and we'll try to extrapolate those findings and maybe comment on our own practice. So there has been a persistent interest in twice-a-week hemodialysis. If you search PubMed, twice-weekly hemodialysis, you'll find around 187 articles since the start of time. But the basic interest was generated during and after the times of COVID, when there was an attempt to switch the patient from thrice-a-week to twice-a-week in order to reduce their exposure to the virus. The interest in incremental or twice-a-week hemodialysis basically started from patients who were on CAPD, because those patients, they had better preserved residual renal function, and residual renal function, if it is well preserved, has been associated with significantly improved biochemical control like phosphate, anemia management, better nutritional and dietary intake, better volume indices such as blood pressure control, and it is also found that even 1 ml per minute of residual renal function has significant prognostic bearing. Right? So it looks very insignificant in the numbers, but the prognosis is really effective. So basically the idea was, both in CAPD and as well as incremental hemodialysis, to try to preserve the residual renal function, because it has a direct bearing on the long-term and short-term prognosis of the patients. So then the question is incremental hemodialysis, is there any evidence that it protects residual renal function? And we're going to draw the conclusion of incremental from the studies on incremental hemodialysis onto our own patients, although we note that our patients may not be actually candidates for incremental dialysis, and we're going to comment on that. Say, for example, in this study in 2019, they found that patients on twice-weekly hemodialysis had a significantly better preserved residual renal function as compared to patients on 3 times per week dialysis. Remember, incident dialysis patients, incremental hemodialysis, they have good residual renal function. But furthermore, the basic or the main difference between the residual renal function in the patients who were on twice a week versus thrice a week was actually seen in the first 2 to 3 years. So if you are thinking of putting patients on twice a week dialysis, the basic or the maximum advantage that you are going to get is in the first 2 to 3 years of their dialysis history. And again, commensurate with those findings, they also noted that the rate of ultrafiltration was significantly different, lower in patients on twice-weekly hemodialysis in the first 2 to 3 years. After 3 years, it was not statistically different. Right. This is another study commenting on patients on twice-weekly dialysis, published in 2016. Interestingly, it's a very interesting slide. They found that if the patients had a residual renal function of KRU of 3 ml per minute or more, and they were given twice-weekly hemodialysis, you could achieve a weekly standard KT by V of 2.1. But if the residual renal function was less than 3, by twice-weekly sessions, it was not possible for majority of patients to get that standard KT by V of 2.1 per week. In this study, again, the residual renal function was better preserved in patients on twice-weekly dialysis as well as urine output. At least up to 5-year mortality was similar between patients on twice-weekly versus thrice-weekly hemodialysis. And if you do a subgroup analysis, you will find a very interesting finding that patients who had a residual renal function of 3 ml or more, patients with a urine volume of at least 600 ml per minute per 24-hour or more, and patients with weekly intradialytic weight gain of less than 3%, they were doing as good on twice-weekly hemodialysis as compared to patients on thrice-weekly hemodialysis. Now, we can draw some conclusions because we are dialyzing all the patients twice a week, and maybe patients in our setup who fit those criteria might be more suitable to be continued on twice-weekly, and maybe we need to switch the remaining patients up to thrice-weekly. So then the question is, how many patients would be suitable to undergo twice depending on this criteria, right? Right, this is another study, and we are going to discuss that percentage. This is another study, again showing similar survival between patients with twice-weekly dialysis versus thrice-weekly, but there are increased chances of sudden cardiac death, and that is understandable because patients on twice-weekly dialysis have probably got more electrolyte derangements, and so if you have patients on twice-weekly, then you have to maybe closely monitor them for electrolyte abnormalities. This is a randomized control trial. So the orange backgrounds are all randomized control trials, mainly conducted in China. And they found out that if the single pool KT by V per session was 1.8 compared to 1.2, the patients with a higher clearance had significantly lower major adverse cardiovascular events. I mean, that is very strange because 1.8 is quite high as compared to the 1.2 for the guideline, right? So then we can probably think that if we have a program with patients on twice-a-week dialysis, maybe that 1 or 2 dialysis that we are doing have to be more robust. Maybe we have to offer them more clearance instead of just giving them the standard KT by V of 1.2. That 1.2 is for patients on thrice a week, not for twice a week. So then there is another randomized control trial from 2020, again from China. Right, so we're not going into the detail because of the scarcity of time, but they found out mainly that the cost of patients who are on twice-a-week dialysis was significantly around 40 to 50% lower as compared to patients on thrice-a-week dialysis. Their biochemical parameters were all similar between 2 and 3 times per week dialysis, except for the lipid profile, which was more deranged in patients on 3 per week sessions, right? So twice a week per sessions, patients were doing sort of better. The adverse events were also similar between the 2 groups. And this was the main finding of this trial. And this has been replicated in so many studies that the quality of life of patients on twice-a-week dialysis is better as compared to patients on thrice-a-week dialysis. But which patients? That is what we need to know. So this is another randomized control trial from 2022. So they screened around 321 patients for eligibility to assess their suitability to be placed in twice-a-week dialysis, right? And they could only find that 100 of these patients, depending on the inclusion criteria, which include a better preserved residual GFR, a better preserved residual urea clearance, and significant urine output, they found that only 30% of their patients could ever be considered for twice-weekly dialysis. And maybe in the same manner, 30% of our patients are probably suitable for twice-a-weekly, and maybe we should be switching our 70% patients to thrice-a-weekly dialysis, right? So this is an interesting finding. Despite the fact that patients on twice-a-week dialysis, most of the studies show that they do at least as well if they have good residual renal function, their bicarbonate level remains significantly low. And therefore, these patients are exposed to chronic acidemia and will need close monitoring as well as bicarb replacement. In comparison to thrice-a-week, patients on twice-a-week dialysis significantly lower hospitalization and serious adverse events. The residual renal function was better preserved in patients with twice-weekly dialysis, although in this study, it did not reach statistical significance. All the biochemical parameters were similar between the patients on twice-a-week versus thrice-a-week, except that to control phosphate in patients on twice-a-week dialysis, they needed higher doses of phosphate binders, and their bicarbonate was low, so they needed supplemental bicarbonate. Also, the volume parameters were similar between the 2 groups, but the patients on twice-a-week dialysis needed more antihypertensive medications to control their blood pressure. Quality of life was similar between the 2 groups, and this is the final conclusion of this randomized control trial. Although in this trial, the rate of loss of GFR was similar between the 2 groups as opposed to the previous evidence that we have seen, but the rate of hospitalization and the cost of medical therapy was significantly lower. So this is another randomized control trial. Again, if you see starting GFR of at least 5 mil. So these patients are not truly anuric. They have got substantial residual renal function. And this is very interesting. So at the end of the trial, the urine output was better in patients with twice-a-week by 51 basis points. The urea clearance was better by around 6 basis points, but the creatinine clearance is in the fine print, but probably you can see it was better by 38 basis points, meaning that twice-a-week hemodialysis was preserving creatinine clearance a bit more than it was preserving urea clearance. And that is probably because of probably explained by a better preservation of residual tubular function by twice-weekly dialysis as compared to the filtration function only. And residual tubular function might be associated with your prognosis because remember the middle molecules, they are not freely filtered and primarily secreted by the tubule. So if these patients have got a better residual tubular function, maybe that is playing into the improved prognosis that we are seeing in some of these studies. Right, again, same result, rate of hospitalization, serious adverse events, significantly low in patients with twice-weekly hemodialysis. Right, so this is another randomized control trial. This is very interesting. So the same finding. They are screening 185 patients to be included in your twice-weekly program. What they find out was that depending on their inclusion criteria of good residual renal function, urine output, only around 41% of their patients were ever eligible to be included in twice-weekly dialysis. So if you take these findings, maybe only 30 to 40% of our patients will probably be suitable to have twice-weekly dialysis, and we need to upscale the remaining to thrice-weekly. Right, so this study primarily focused on symptoms of the patients and showed that dialysis symptoms reduced in both groups, twice-weekly or thrice-weekly dialysis, equally, but the patients on twice-weekly dialysis had significantly reduced anxiety and had significantly reduced depression, at least early on. So this is meta-analysis, most recent, published in 2023, around 36 articles, some 136,000 patients. This includes all the studies that we have discussed and many more than that. The most interesting slide of this systematic review meta-analysis is that you see that in the last few years, these are the trials that we have discussed up till now, and even some of the previous studies. Patients who were undergoing twice-weekly hemodialysis had significantly preserved residual renal function, at least a residual urea clearance of 2 or 3 ml per minute with urine output of at least 500 ml per minute. So if you want to extrapolate the findings of this systematic review meta-analysis to your patients, you can only do that to the patients who fit into these criteria, not to the patient who's completely anuric or who has no urine output or no residual renal function. So this is the summary of the slide that I have made. In terms of the solute clearance and a few other endpoints, twice weekly is similar to thrice weekly. In terms of loss of residual renal function, urine output, interdialytic hypotension, and clearance of middle molecules, twice weekly patients are doing better than thrice weekly, probably because of better preservation of residual renal function. This is the forest plot showing loss of residual kidney function is better in patients on incremental twice weekly dialysis. This is a forest plot showing rate of hospitalization is better in patients on twice-weekly dialysis. This is very interesting. If you see overall, the mortality looks to be similar between twice a week and thrice a week. But if you take the subgroup, which has a better preserved residual renal function with a residual urea clearance of 2 ml and urine output of at least 5 ml, it seems as if the patients on twice-weekly hemodialysis are doing better, are doing better than patients on thrice-weekly hemodialysis. So just to summarize, in terms of loss of residual kidney function, twice-weekly is doing better. In terms of hospitalization, twice-weekly is doing better. In terms of cardiovascular events and mortality, they sort of look similar, but if you take out that particular group with a significant residual renal function, it seems as if the patients who are starting dialysis have good function, they would have a better prognosis as compared to the patients on 3 times. So regional studies, just to run through the slides because the last slide is the most important. This is the only study from Pakistan from Dr. Zaid Nabi's department from KRL showing twice-weekly hemodialysis patients having better quality of life. From China, we know that around 25% of their patients are on twice-a-week hemodialysis, and their studies also show similar 2 to 3 year survival between these patients. And interestingly, in this one article, they were giving 4.5-hour sessions to the patients who were on twice weekly as compared to thrice weekly dialysis. So they are giving a higher dose per dialysis to their patients. This is from India, and probably most relevant to us. 80% of their patients, this is an old study, 80% of their patients were on twice a week, like we have, with 5-year survival of only 20%, so around 20% per year mortality, which is probably similar to what we have. in this article, again in 2017, the intermediate term measures were also poor as compared to thrice a week, and blood pressure control and hospitalization rate and major adverse cardiovascular events were poor in patients on twice weekly than thrice weekly. Now, this is completely different from the studies that we have previously seen, which show that the patients on twice weekly are doing better. So in India, it's the other way around. And the answer to that question probably comes from the Indian studies themselves. So for example, we have these two papers. One is from 2015, and it shows that only 28% of their hemodialysis patients were ever meeting the adequacy criteria. And this another paper from 2021 shows that although single pool per session KT by V was adequate in 70% odd of their patients, which means the per session the clearance was good, the standard weekly KT by V of 2 was achieved in only 10.1% of the patient. That suggests that yes, per session the clearance was very good, but overall weekly clearance, which includes the residual renal function, that was not good, and therefore the patients were not getting the total weekly KT by V that is recommended. And that suggests that this rationing of hemodialysis to twice-a-week sessions is basically based on financial considerations rather than true clinical pointers, and that is probably the case in our setup as well. So if you want to draw recommendations for our setup, you need to flip the coin. We need to, like in trials, they included the patients with significant, with a few cutoffs, and since we are dialyzing all our patients at twice a week, we need to flip the coin and see if the patients do not fit those criteria, we need to switch them up to thrice a week dialysis. Say for example, in trials around 50 to 60% of the patients, they were not suitable. Only 30 to 40% of the patients were suitable for twice a week dialysis. So maybe we should be thinking of switching 60 to 70% patients to thrice a week than twice a week sessions. In trials, incident hemodialysis patients were included, and the benefit of preservation of residual renal function was especially seen in the first 2 to 3 years. So maybe the patients that we have that are starting dialysis, we can start them on twice a week, and maybe after 2 years, when their residual renal function declines, we have to switch them to thrice a week regimen. In trials, patients with heart failure and cardiovascular disease were excluded, and maybe we should be more selective in taking the patients, and maybe patients with heart failure, we should be starting them and keeping them on thrice a week rather than continuing with twice a week. So we are actually reversing the logic over here. In trials, almost 100% of the patients were on diuretics, around 40 to 60% of patients were on supplemental bicarb, were on Petaromur and needed higher antihypertensive dose. So if we have got patients on twice a week dialysis, we should take care of their blood pressure, volume status, bicarbonate, and other potassium and other biochemistry more closely as compared to the patient on thrice a week. The trials included patients with residual renal function of more than 3 and urine output of more than 500. So if we have a patient with residual renal function of less than 3 and output less than 500, maybe this is the time to switch him from our twice weekly to thrice weekly regimen, and efforts should be made to preserve their residual renal function. This is the last slide and our recommendations. Thank you.
Presentation about twice a week or thrice a week dialysis and residual kidney functions. Let me ask the audience, which are all eminent nephrologists, are you able to convince the audience to go for twice a week or thrice a week? There are two. Comment. Okay. Yes, by all means.
I think most participants are getting the message that in these, this specific patient population with residual renal function of more than 3 ml per minute, if you dialyze them more frequently than twice a week, these patients will do worse in terms of clinical outcomes. And I think there is no objective data in any of these studies to prove that. These patients are already doing better because they have residual renal function and they are just less sick. So for financial reasons and for convenience of patients, you can advocate twice weekly dialysis in this subgroup, but I don't think this data suggests that if you dialyze them 4 times a week, or 5 times a week like in France, I think more frequent dialysis may lead to even better outcomes. So we need to be careful about what we are saying and the message that we are conveying to everyone.
Yes,
like if you do dialyze these patients 3 times a week instead of twice a week, are you harming these patients or not? That is my question.
No. Basically, if you see the slide, if I can get the slides back, the prognosis of the patients on twice a week, if they had a good residual function, was at least as good as the patient on this. It's sort of a non-inferiority type thing. So I'm not saying that they are any superior. I'm saying that if you want to choose twice a week dialysis, you need to be very selective to find the patients whose prognosis would not be hurt if you give them twice a week dialysis. So their prognosis should at least be similar to the patients on thrice a week. So
And the other question is, if we dialyze them more frequently, is it better for these patients, or is it going to harm those patients?
No, the data that I have presented has not answered this question.
But
that's for another talk then.
So I think practically what Balig has said, we all are doing that, because in a resource limited country, even in our center, those patients who have good residual renal function, we are keeping them on twice dialysis. But those who have some cardiac issue, who are really anuric, probably sometimes they come in frequently in fluid overload, so we have to keep them on thrice weekly dialysis. So
I totally agree with Zahid. Under the ideal condition, thrice weekly is absolutely right. But under the local conditions, we usually recommend twice weekly, and if the indication which we have told our problems are there, then we go to thrice a weekly. But
Yes.
keeping all the financial factor, the travel time, the local area, usually majority of the center in our country are doing twice weekly. But there's no doubt thrice weekly is better.
So I mean, you can dialyze the patient 6 times or 7 times a day if you want. I'm not commenting on that, right? So there's no
Actually,
question
we
about
are
that.
dialyzing most patients 3 times a week, and our outcomes are pretty good. I mean, the only question was people should not get the message that if we dialyze people with residual renal function thrice a week instead of twice a week, that would be like malpractice or a bad thing to do. That was the only
That is the
concern
standard.
that I had.
That is the standard. Yeah, 3 times a week is the standard guidelines.
May I add a comment to it? Maybe this leaves an impact that emphasis on initiation of early dialysis may help the patient. Maybe this is the impact of the data that you have presented, that patients with a better preserved renal functions will do better with a lesser burden, financial burden on twice per week hemodialysis. So initiation of dialysis earlier, maybe this is the message, better message.
Let me conclude it. Our population often asks all of you, Dr. साहब, ये dialysis महीने में एक बार हो सकता है? बाद साल में भी एक बार करना चाहते हैं. तो गुजारिश ये है कि nature, which is Allah subhanahu wa ta'ala, it cleans your body 24 hours a day. Allah ta'ala cleans your body 24 hours a day. So limiting the dialysis dose because of financial reason and other factors probably may be acceptable in exceptional environments, but twice a week dialysis may not alter the prognosis, but rather we have seen clinical practice, it always end up into multiple complications of the under-dialysis. Thank you very much, Mufti Sahib.
Thank you.
You had a difficult topic to discuss.
Thank you, Dr. Mufti, for raising questions that challenge conventional practice while respecting contextual realities. Progress often begins by asking uncomfortable but necessary questions. Anemia management is entering a new era. Hypoxia-inducible factor stabilizers are redefining pathways we once thought were fixed. This session will bridge molecular science with bedside application. I invite Dr. Behram Khan, consultant nephrologist, to kindly talk on this program. The panelists for this talk are Professor Azaz Mand, Dr. Tasadduq Khan, Dr. Zahid Nabi, and Dr. Syed Mani. Thank you.
Hello, good morning, PSN. Thank you for having me today. It's a pleasure. I'm Dr. Behram Tariq. I'm a consultant nephrologist and, from the northeast of England. And today we're going to be talking about the revolution of HIF stabilizers. I think one of our colleagues has already given a nice presentation yesterday, and they give some local perspective of these new molecules. So I have no disclosures to start with. And the objectives today is to talk about what are these novel therapies, how they have revolutionized in anemia management. I think there's a good debate going on between the safety and efficacy of these medications. How are we using them in our day-to-day clinical practice? And I'm happy to give you my perspective of what we are doing in our center in the United Kingdom. What population should we be choosing to start these medications on? And how do we see the future of these novel therapies? There may be some repetition of the slides from yesterday, but I'll try to make it as interesting as I can. So let's talk about the evolution of anemia management. We are in almost half a century where we have different agents for treating anemia, from 1950s up to date. I'm not going to take long. We're going to talk and focus on 2019, where different phase 3 trials were conducted with regards to HIF stabilizers. Before that, we had, as we all know, iron and EPO. I'm going to call them ESAs for the rest of my talk, because this is how I'm trained. And for the HIF stabilizers, I'm going to pronounce them as HIF PHIs. So thank you. We know anemia is really prevalent globally, and there are multiple studies showing that. We also know that with the progression of CKD, there is increased prevalence of anemia. And if we don't treat anemia, there are multiple cardiovascular outcomes, which is we are all very well aware of. This is a slide which is taken from KDIGO International, and it is from 2026, very recent one. So what are the, let's keep things basic, because basics are basics, and we should just go back to the basics when we get stuck. Anemia, in my opinion, is just because of 3 different reasons. I mean, there are multiple causes of anemia, and it's kind of, the discussion is focused on HIF. So where does HIF inhibitors comes into the paradigm of treating these difficult patients or anemia of CKD? We know iron, we know EPO, and now the paradigm has shifted to hypoxia-induced factors, and this is in different pathways. Do we have any limitations for the already existing therapies that we have? And yes, we do. There are some pros and cons of the use of iron, and there are some pros and cons of using erythropoietin stimulation agents. And there are some trials and studies which have suggested that increased dose of erythropoietin stimulation could also lead to cardiovascular events, which is kind of the same clinical inertia build up regarding HIF inhibitors. And we're going to talk in a sequence how this has been revolutionized. And let's see if we can have some correspondence from the local practice as well. So, what is HIF? HIF is hypoxia-induced factor. These 3 genius scientists discovered them in 2019. What happened was they sense oxygen at a cellular level. The discovery started in 1999 and took them about 20 years to come with these beautiful concepts. It's important to know about the pathophysiology. What happens in a normal state when the body is not in hypoxia. HIF PHIs or HIFs are down-regulated, they are degraded, so they don't have any end outcome mechanism of action. When the body is in a hypoxic state, high altitude, and I have recently observed when I used to do our GIM ward rounds, when a patient with COPD would come in and they would we would do a normal CBC or full blood count, they would have essential thrombocytosis. We didn't actually look into that. Why is that the cause of essential thrombocytosis, where it's one of the indications for giving them home oxygen? Now I know that they have this normal pathophysiology of having HIF inhibition. So it's important to know about these two processes, number 1 and number 2. There's a lot of debate on the cardiovascular safety, and various meta-analyses have actually focused on this part where different agents act differently. So what happens when the prolyl hydroxylase enzyme is disinhibited? The HIF-alpha does not go degradation. It goes down into the cellular level. At the cellular level, it forms a sister subunit to form a dimer. Forms 2 units. They go dimerization, translocation, and also genetic remodification. After this, they expresses more than 50 genes. So just not only acting on the kidneys, but they have a wide pathophysiological changes in the whole body. How does HIF-PHI comes into role? So these are basically molecules which does the same job when the body is in a hypoxic state. My next slide is important, and it shows a lot of the pathophysiological changes, which will explain how these HIF inhibitors or stabilizers causes the increased endogenous production. And it's very interesting. It's really good science. I would really like you to focus on 2 sections of this slide. The left side, where it acts on the bone marrow, and the right side, where it acts on the duodenum and the antral cells. So we know once at a cellular level, there is gene expression. There is a direct effect on the kidneys, where it produces erythropoietin. Erythropoietin then acts on the bone marrow to produce more red blood cell. Now, it gets more interesting. This molecule called erythroferonone, this is a precursor of red blood cells, and it affects indirectly on the liver, which causes a reduction in the hepcidin level. And I'm sure we all know that most of our population is in a pro-inflammatory state, and they have a high hepcidin levels. And then let's focus on the left side. How does it have a direct and indirect effect on the iron kinetics? So with these EPO gene expression, they increases the iron absorptions from the gut, and it gets more excited with these small little molecules called FPN. These FPN molecules actually get saturated when there is high hepcidin level. So with this concept, if the hepcidin levels are low, this molecule does not saturate. It gives a good pathway for the absorbed iron to get translocated to the bloodstream. So I take 3 messages from this slide. 1, it increases erythropoietin production. 2, it helps in iron kinetics. 3, it also reduces the inflammatory state of our body. I think at the moment, if it does that, we are winning with our anemia of CKD. Okay, pathophysiology done. Let's talk about the new novel therapies that has been approved throughout the globe. So we have 6 agents that has been approved globally. Talking at the top is daprodustat, which is approved in the United States for non-dialysis CKD. It is approved in Japan for dialysis and non-dialysis CKD. These 3 agents are mainly being used in Japan, whereas where I'm from, United Kingdom, we have roxadustat and vadadustat licensed for our practice. Roxadustat is used in non-dialysis dependent CKD and dialysis dependent CKD, whereas vadadustat is only licensed for dialysis dependent CKD. Now, I'm sure you guys are only focusing on the drugs, but there's a lot of data here. we have a lot of variability in this slide. And the variability is that there is different doses, there are different half-lives, and later on, when we're going to have a constructive debate about the safety profile, I'm going to focus on these 3-4 other parameters of these molecules. So, the message from this slide is that they have different plasma half-life. Some have great half-life, some have low half-life, and there are a lot of variability in doses. This slide is taken from KDIGO International, which tells us that these are actually available globally. They also gives you the initial dose, the maximum dose. They also give you a very nice explanation of the different cytochrome inhibition and vice versa. So, if we talk about the revolution, we've just spoken about the pathophysiology, the mechanism of action, and it has been now incorporated into our KDIGO guidelines. When some molecules or compounds or drugs are approved, there should be some data behind it. So let's talk about that. Before I mention forward, I'm going to keep it simple. I'm not going to go into deep down to the statistics, and I really try to be non-biased, so I'm not selecting any particular drug. But there has been various randomized controlled trials globally performed, more than 50, with regards to HIF-PHIs. And all the compounds that I've shown you, they are widely studied, and they're studied from Japan, China, India, UK, Europe, and as well as America. So, what were the major comparators? They looked into standard erythropoietin, which we call as ESAs, and placebo controls. And what did these trials concluded? These are big randomized controlled trials, so good evidence. And they say, effectively increases CKD. It also says that they are non-inferior to ESAs. They are superior to placebos. Now we're going to talk about the MACE, which I think a lot of people are debating about with these medications. If we looked into these randomized controlled trials, the oral MACE was similar to erythropoietin stimulation, and again it was non-inferior to ESAs. I am aware that there were some safety signal raised in these randomized controlled trials, and we're going to discuss how these safety signals were highlighted and what in the course of revolution where we are and how we have moved on and what our future would be with these medications. So the takeaway from these randomized controlled trial was, one, this drug is clinically effective and it is clinically safe. It's non-inferior to ESA and it has safety comparable to ESAs. It stimulates erythropoietin, it has iron metabolization, and it may reduce IV iron. So it is doing exactly what its pathophysiology is. What other benefits are of HIF stabilizers or HIF-PHIs? It has a very good role in the iron kinetics in the body, and I hope I've explained it to you in my pathophysiology slide. We had a controversies conference where they talked about the evaluation and efficacy and safety of these medication. There was also a webinar on talks about these safety questions, concerns, and this is because there was a lot of variability. They had questions about the time period of the trials, they had questions about the target hemoglobin, the roxadustat hemoglobin targets were different for different drugs. There were the non-inferiority margins had a different variation. But then also they highlighted that there may be some risk of cardiovascular concerns. But then these concerns were raised mainly primarily in trials that conducted were conducted as a comparator with placebo. When they looked into in various meta-analysis, it actually didn't highlight it as if they were with the randomized control trials. And why we have these highlights, because as I explained, these are molecules that affect on various different parts of the body, which we have already seen. It has an effect on iron metabolism, it has an effect on inflammation, it has an effect of erythropoiesis, but also these different complex biological targets are also being targeted. Hence, we have this proposition and theoretical risks about its angiogenic effect and oncogenic effect. So we have multiple meta-analysis. So in the revolution, we had randomized control trials, and now we're going to talk about the meta-analysis. Various meta-analysis happened from China, from Japan, from America, and from Europe. And these two ones, the network meta-analysis, and as well as the efficacy and safety analysis, which happened in Europe, is worth a read. And I'm going to focus on this meta-analysis because this was conducted in the European Union, and it was conducted by French and Italian doctors. And the questions that were raised previously in the different randomized control trials, they tried to mitigate those questions, they tried to mitigate all those biases and come up with an informed decision. This trial was really important because they conducted this trial over 2 years, so the time period was good. They excluded all patients with placebo, again, because of the placebo trial tend to overestimate efficacy, so hence this is better than the previous randomized control trials. And they also included all phase 3 randomized control trials, so they had 27 RCTs included. Another trial, the non-meta-analysis, network meta-analysis, they had 37 RCTs. What the conclusion is going to be, because of the time frame, focus on the safety outcome. The confidence interval in this meta-analysis was statistically not significant, and it was compared to erythropoietin stimulating agent. And the conclusion from this meta-analysis was that no significant safety signals emerged with the use of HIF-PHIs. So what is the rationale for using these medications now when we have good RCTs, we have got meta-analysis, they have actually looked into pooled analysis with subgroup analysis? I think we have a boosting molecule, we have PHIs that treat anemia by boosting red blood cells, and different trials have shown and backed up this efficacy and as well as shown that the safety profile is similar to other standard therapies. However, obviously we have to take safety into concerns. Treatment should be tailored with each patient's specific factors. So this is the last session of the presentation where I'm going to say, how am I using these medications in my clinical practice? So I usually follow, or we should follow, these suggested guidelines and recommendations from KDIGO. The first thing they have emphasized is that it is a shared decision making. So when we want to start or stop or reduce or increment or decrement any of these medications, it should be discussed with the patient. And patient selection is really, really, really important here. And that's where the emphasis has come all across from these randomized control trials and a meta-analysis. We have to look into patient symptoms burden. We also have to look into if they really need to optimize their anemia, if they are symptomatic. If we want patients to go onto a transplant list and we want to optimize, for example, not give them blood transfusion for desensitization, we should be using these agents. And there has been some good guidelines and suggestions given now which patients should we be looking for who has adverse outcomes. UK Kidney Associations has put them on their guidelines that these are used in non-dialysis CKD patients, dialysis-dependent CKD patients, and EPO-hyporesponsive patients. They have emphasized again that all these patients, before initiating HIF-PHI, should be iron repleted, so they should have iron repletion. ESA hyperresponsiveness is also important here, but I'm sure you guys all know about it, but there's a good definition of ESA hyperresponsiveness in KDIGO guidelines. What does this slide actually say is that patient in whom we want to treat anemia secondary to ESA hyperresponsiveness, we should give them a trial of HIF-PHIs. This is what KDIGO suggests and recommends. If we have to use HIF PHIs in this certain population, we should be using the lowest drug available of whichever compound you would want to choose. The risk factors has been nicely postulated and given us in a tabular form. These are all theoretical and experimental risks based on the evidence. Polycystic kidney disease were not included in the trial. They are contraindicated in pregnancy. There is a debate about proliferative retinal disease. What we do is, if a patient has previous retinopathy and it has been well treated and they are fine, if the patient is still wanting to go on HIF inhibitors, we prescribe them. If there is untreated retinopathy, we don't treat them. There are some concerns about thromboembolic diseases, but I think we have examples where ESA has caused a lot of thromboembolism as well. We have to be cautious in whom we give them. If there is a patient who's had a recent MI with significant cardiovascular disease, quadruple bypass, or a recent stent, or a recent stroke in 3 months, of course, we'll be very judicious in our clinical judgment whether they should be on these medications or not. In fact, they have emphasized that we should be cautious with all these risk factors. UK Kidney Association has put this on their guidelines, that we should be cautious with these patients. Where does it take us to? UK Kidney Association, KDIGO, the European Union has given us a really good clinical practical document about how, when, and where should we be using these medications, and which are the patients that we should be watchful about. It's similar, what I have already discussed. It is indicated for non-dialysis CKD. It is also indicated for dialysis patient. With caution.
Sir, please time over.
I'm going to take 1 more minute. Sorry, apologies. Monitoring is the really key point here. And I think if we have active monitoring for these patients, I'm sure the inertia which has been built up about their safety profile can be mitigated. So what we do is we usually review them 4 weekly, and we see the response. If the hemoglobin is raised by 2 grams in 4 weeks, we either reduce the dose or we look into the patient's perspective and then either stop it or restart it at a later time. There are some pros and cons, which I think with the time constraint I won't be able to discuss, but I'm happy to be contacted. I'm going to be sticking around. So here's my opinion. These are heterogeneous. They are not homogeneous. By that I mean they have the same mechanism of action, but if I quote, for example, roxadustat has a different inhibiting pathways of the prolyl hydroxylase enzyme. Doxadustat has a different pathway, and vadadustat has a different pathway. That is why there's a lot of variability in the safety profile. Treatment should be based on patient risk factors. We should be discussing it with our patients, and we should have robust pathways. It is interesting to know, when I spoke to a lot of my colleagues here, what are you guys doing? And they say, oh yes, Baijan, we are prescribing them. We have patients who are on XYZ drug from the past 3 years. I said, if you have these patients for the last 3 years, where is your data? Why don't you just come up with some observational study first, or then talk to your seniors, then they can plan some multi-center trial from, or randomized control trial from Pakistan. I mean, this is what we are needing for. So this picture at the end, I think 10 seconds, is we have a mountain of information here. We have randomized control trials, we have good scientists involved, we had controversies, conferences, we have debates in ISN and KDIGO. This is us, where we have the knowledge and we are at the peak there. But we're going to reach top there. There are scattered data which we have to go through thick and thin to go to the pinnacle of prescribing these medications or other medications with more robust, less clinical inertia. I hope we'll have further debate in the question and answer sessions, and I thank you here very much. I can't hear.
Thank you, Dr. Bahram. Excellent presentation. And I think we should, since there is some controversy about the use, shall we ask the audience
Of course.
That if they have any experience or if they have any comments to make before we conclude.
Thank you, Dr. Biram. Very, very beautifully explained everything. I actually talked about this yesterday. And I feel this is still a debatable subject, like the previous lecture we had this morning. And again, I want to know in UK, how do you guys practice? Are you replacing EPO already? You're starting these drugs on patients with CKD and hemodialysis? That's one question. And other, there is little clarification, even though KDIGO had different, the guidelines here, but in US, it has not approved yet on CKD patients. It's approved by FDA, only on hemodialysis patient, and also only on hemodialysis patients who are EPO hyporesponsive. So that's where we stand right now, and they're not using it that much. So that's why there's a big problem, and a level of comfort to use them is still, difficult.
I think first of all, we shouldn't say it's a big problem. We are at the end clinicians, and we should be a bit rational in our decision whether one patient XYZ is going to benefit from it or another patient XYZ is not going to benefit from it. You asked me what is my perspective when I'm practicing in the UK. I think I'm trying to be non-biased here based on the research that we have available and the different meta-analysis that are available. Obviously, you guys know that we are using roxadustat. My practice for these HIF-PHIs is, if I want to start them, I'll start them on non-dialysis CKD patients. And an example I'll give you is, for example, there's a patient who is Mr. X, or let's call him Robert. He's 82 years old. He's got chronic kidney disease, but he only had a comorbidity of hypertension. But otherwise, he just have a kidney disease because of his frailty or aging. He's got anemia now, and I have a shared decision making with him, and he opts for one of the HIF-PHIs. I will give it to him. So that's one of the examples for non-dialysis CKD patients. Let's go on to the example of dialysis patients. If I start, and which are actually the recommendations for roxadustat in our practice, if we start them on roxadustat and they are non-dialysis, when they move on to dialysis, we don't switch. You can continue on them. This is what they have recommended, and this is what major trials have been done as well. So this is our practice. All my colleagues are doing the same. If we see when they are switched on to dialysis and they have no response, we do switch them to ESA and see if they are responding or not. So as you all know, these are novel therapies, and I still take them as, for example, these medications. For example, we had clinical inertia in prescribing SGLT2 inhibitors, et cetera. When the guidelines became more clear, there were more practically we were using it more and more, so hence we're starting to use them more. With regards to your other questions, when it comes to prescribing them in non-dialysis population, and if I quote from different meta-analysis, the debate's going to be lengthy because this is a debatable topic. They are heterogeneous, and when I say they are heterogeneous, that means different molecules have different mechanism of action. For example, there are PHD1 receptors, PHD2 receptors, PHD3 receptors. There are also different isomers of the prolyl hydroxylase enzymes. Within these network meta-analysis, they have actually found out that one of the HIF-PHIs, which I'll quote here, is roxadustat and daprodustat. They didn't find any big differences when they were used in non-dialysis dependent CKD or dialysis dependent CKD. In fact, some trials from this pool analysis suggested that daprodustat is more benefiting patients on dialysis other than roxadustat. Therefore, roxadustat may have not been the first option for patients in the United States. They also looked into the safety profile, and there were various hierarchies, but there's no significant randomized controlled trials head-on-head with each other. So we still have to go a long way. We still have to go to have more randomized controlled trials. The last answer to your questions was, if we look into who benefits from them, I think it is based on patient selection criteria. And let me give you last example. There's a patient, right? And we know a patient has thromboembolic phenomena or their oncogenic effects. I had an MDT the other day with my colleagues. There was a patient who had end-stage cancer. It was widespread in the body. We knew that she does have poor prognosis. And we actually sat down with her. We made a shared decision. Said, these are the two options. Do you want to go for subcutaneous injectables, or you want to go on an oral just to improve your quality of life? And that's been proven that most of these HIF-PHIs in meta-analysis can also improve your quality of life. And she opted for one of the HIF-PHIs, knowing the fact that we have cancer. I mean, this is what we say, it's rational, judicious decisions, and we take case by case. Thank you.
I think I'll interrupt here. Professor Magdi.
Hi, Bharam. Hello. Nice to meet you in person. Heard a lot about you.
Thank you.
I'm at Royal London. I think the audience here needs a bit of reassurance.
Yeah.
We are looking at a country where shared decision-making and MDTs, etc., are a bit of a luxury. So let me start by reassuring and telling you that we use it quite more liberally, as Ram was saying, okay? And let me tell you that the first molecule of HIF stabilizers was given to me to use it in my lab in 1995, okay? So I have used it both experimentally and clinically now. For me, it's a whole cycle. Why I feel so safe that when I went to Denver, which is a 1 mile high city, right, there was hardly any use of EPO. The nephrologists there used to moan because in America, if you give EPO, you got extra money as a nephrologist. That's why they've introduced one bundle to cut the cost. At that time, for everything, they used to get money. And Denver nephrologists used to moan that our patients are not on EPO. It's 1 mile high city. There was a natural HIF in their body. They had hardly any anemia. It's a naturally active HIF. And if HIF was that dangerous, don't you think that there will be increased mortality, increased cardiovascular mortality in Denver patients? This is a natural model. Your HIF is up naturally. If you go to Tibet, there is no use of EPO in Tibet dialysis patients. And up till now, no epidemiological study has shown, even with or without CKD, there is increased risk of anything. That is your natural model. There is a genetic mutation, which is called CGLN, where this HIF1 is inducible. It becomes inducible. It's not constituted. Not VGF. VG is different. This is different. Okay? They get erythrocytosis. They are the best blood donors. Every 6 months they come, bleed, is a normal blood. Have they come to any harm? Of course not. We should learn from nature. Okay? And I just say for you guys that many of the people who are living in Himalayas, they will be hardly needing EPO. Go to Mirpur, in Kashmir, there will be hardly any use of EPO. Because your body is naturally making EPO. Even your naked kidneys can make EPO. That's what this study has shown. That your kidneys are dead unless you are anephric. Even anephric patient will make EPO from the liver.
Thank you very much. I really appreciate that.
So please be reassured. And just be a clinician, because every patient, whichever drug, even if you use vitamin B, it has got its danger. You have to be careful. Be reassured it can be used. Do you think EPO is without its effect? Just half of your patients don't even have freezer at home. How many people, of the people you look after, have a freezer to just store EPO properly or insulin properly? doses they use. The only plea is that the drug companies cut the price. That is what you should be angling. Whether it's safe or not, give the choice to the patient as you do, EPO versus no EPO. But the bottom line is that there are advantages of this drug in this country, where there are no freezers. How is the safely your insulin or even EPO is stored? A tablet, but monitoring is required for everything. You've got to be vigilant. So, Bahram, I'm sorry to say, yes, whatever you said, it was your duty. My last slide of your talk would be, go ahead and use it.
Go ahead and use it.
Thank you, Professor Yaqub.
Thank you.
I think your comments are very relevant to our population because
question, please.
We have patients who don't even inject insulin themselves. They need a family member to inject insulin. And injecting erythropoietin is an arduous task for them. And similarly, the cost is a big issue. The preservation, the cold chain, everything we have to keep into account. So maybe countries like, of course we don't, want to go away from the guidelines because guidelines are based on something. And that's why there must be a cutoff. And you're talking about Hunza and Gilgit and places because there is natural, they are at an altitude and they have hypoxia. And that's why they keep their hemoglobins up.
The last thing, Baron, in your slide, you should use in your talk, when you're going to the developing world, which is now the dumping ground of our waste from waste here, all this biohazard, which is the injections, come here to be buried. By not getting the injectables, which is a biohazardous substance that also protects the climate by taking a tablet. No microplastics, no nanoplastics. So there's a lot to gain. The bottom line is that you can't be a non-thinking doctor with what we have become with EPO. Because we have used EPO for so long, we have just become non-thinking. Just EPO and that EPO will take care of it. That was wrong approach. This HIF stabilizer just refocus how EPO patients should be monitored as well. It's not that you are going to do any extra monitoring. The same monitoring is required for EPO patients, but we don't do it because we have become experienced drivers. We don't even look at the mirror and we change the bloody direction.
True.
This HIF stabilizer is teaching us that's how you should be looking EPO patient as well. That's what we need to breathe. I think this is a good thing to have come to just reteach our juniors that anemia management is a complex issue.
Thank you. Thank you very much.
Just last 1-2 comments for Dr. Bahram.
I think Dr. Saeed wanted to say something he was
Dr.
raising his hand.
Saeed.
Has he left?
I think he left.
Carry on, carry on.
Just, sir, I just wanted to tell you that, yes, you guys are thinking pretty well that we are living in a stone ages. But to be very honest, we are quite advanced now. And we are doing shared decision with the patients. We are doing studies. I have already done it on roxadustat. I have done it off-label use in transplant patient as well. And it has already been published. And a multi-center trial have already been started in few centers. So we are doing a lot in research as well. The newer nephrologists, they are into it. And we are trying our level best to cope up what you guys are doing in UK. And sir, you were telling that there is way too much difficulty in the northern areas and places where they cannot capture erythropoietin. Yes, this is absolutely correct. And this drug is effective. And you, as you mentioned, that there is a natural way of increasing erythropoietin. But there are still few patients who needs it. And I think this drug is very effective in those where we were lost with nothing. We were using so many things, and especially I'm talking about transplant. I know it's off-label, but I have used in many patients, and it has given absolute wonderful results. And patients whose hemoglobin was stuck at 9 and 10, it has gone up to 12. So this is my observation. Rest, I'm all sure that you guys are well aware that these drugs are marketed here for last 2 years, and we all been using, but there are still few patients who are not responding on these drugs. This is also important.
Agreed. You may use any of these things judiciously, but at least we should think twice before giving a blood transfusion to the patient. Because of the transplant programs now rapidly evolving, I think we should try to avoid blood transfusions as far as possible in these dialysis.
Yes, sir. As we in the SIN, there is at least 10 to 15 hours load shedding. And we are using this for patient compliance and cost. It is 70% reduced cost than EPO if we use these drugs. In many patients, it is giving a wonderful response. So 90% patients give a robust response. Sometimes we are also confused when we give it 9 HB and after 1 month patient comes, it is more than 13. So sometimes it has very excellent response.
It's important to tell you guys this. So if we, sorry, I'm going to stand up. Puran? Yeah. So Puran's just said that there is a rapid rise in hemoglobin, and these have been actually looked into this pool analysis, and there are some particular drugs that only do that. Not all HIF PHIs does that, and I would quote, it's the roxadustat. It gives you a quick spike, and I think, as we say, when these patients have this quick spike, this is where people start thinking about the increased cardiovascular mortality, or they will have a stroke, or they will have a high blood pressure, or they will have hyperkalemia. But none of them were looked into the pool analysis. What we do for these high spiking patients is we either reduce the dose, we go a step down rather than 70, or we just stop them and then see. Because at the end, we are treating symptoms of anemia. And when it is in the target, which we have guidelines saying if it is 10 and above, if they have persistently achieved that, then you can stop it. So for these patients, when they have a spike, don't worry, I would say. Continue it, but with monitoring. The next time, if it goes up again, reduce the dose. Thank you.
Thank you for clarifying both promise and prudence in this evolving therapeutic space. As always, innovation must walk hand in hand with vigilance. Now coming to the other talk, infections remain one of the leading causes of morbidity and mortality in dialysis patients worldwide. The upcoming talk focuses on prevention, system, and culture rather than cure alone. It is an honor to invite Professor Katie Richards, who is a consultant nephrologist and general physician at Barts Health NHS Trust. She will speak on reducing infections in hemodialysis.
Thank you for giving me this second opportunity to talk to you here in Islamabad, and I'm very much enjoying still my trip to Pakistan. So I'm going to share some of our own data with you to set the context for this discussion. And this is from what we have our dashboard. When we look at our data in our unit in the Royal London Hospital, it's there for us to see every day. And this is looking at the steady rise in our renal replacement therapy patients. And you can see the numbers at the end, and that the vast number of them are on hemodialysis. We do have infections, and we're obliged to report them to the registry. And you can see this is also reported live on our dashboard. The lines represent the upper and lower limits. This is just for bacteremia with Staph aureus sensitive to penicillin. And you can see that we have our own problems and that we stray out of the range from time to time. But despite the increasing numbers, we seem to be managing quite well to maintain within the acceptable ranges. So why does it matter? I tried to do a little bit of local research, and I came across this, this paper in your Society's journal. I don't know if the authors are in the audience, but clearly you already realise that there is a problem. The data is reported slightly differently. Are the authors here, by the way? No, okay. Well, obviously this highlights that you would recognise that this is a problem, which is a good start. And this was looked at, a retrospective study in a particular unit, and they looked at the rate of infection in all of the patients. They reported the total number of infections with the denominator being the number of patients, so it's reported slightly differently. And they also included exit site infections, which is why their number is pretty high. And they were quite disappointed with their results. So why does it matter, sepsis, in our patients? So this graph, it's a little bit difficult to discern the actual numbers here where they refer to the symbols, but I can tell you that the top line is for our dialysis patients, be they white, black, or male or female, and the bottom is the general public. This is a retrospective look from America with the causes of death and the numbers that were related to sepsis in the dialysis population compared to the general population. And it's 100-fold, and it's pretty steady in our dialysis population where it changes in the general population. So sepsis is a significant cause of mortality. This is confirmed by our UK data. This is the renal registry data, which is reported every year in the annual report. And you can see that if you are over 75, you're most likely to die of infection on dialysis. Under 65, and it'll be cardiovascular mortality. But there's little in it. Has this changed over time? Well, no, not really. It's a consistent problem, this mortality due to infection. This is obviously general infection, and you can see the spike here for 2020, and we all know what that was about. And I think sometimes we also forget. So to be reminded occasionally from looking at data over the years, I think is quite important for us to reflect and understand what happened during that time. Well, what is the other cost? Mortality is obviously a very important problem, but cost is also significant when we're talking about infections. This is not real data, this is hypothetical data based on a hypothetical dialysis unit with 300 patients in them all on a line. And it's health economics. It's not a clinical study, but I've put it there to show you what the costs savings can be made where small changes are made in terms of how we manage our patients. So for example, in this case, it would be the lines and also changing to using the chlorhexidine dressing. And I noticed in the first publication that came from the unit in Pakistan, there was a correlation with non-sterile dressings and the infection rate. So this is just to demonstrate to you what the savings could be making a small change. Because when I looked at the data, there were wide ranges of costs for episodes of sepsis due to lines or in hemodialysis patients per se. What might be the other cost? The cost is antimicrobial resistance. I thought this was a very interesting and quite well-written study, and it came from Palestine, and it came from the West Bank before the conflict started. And it was a very well-written study, and I was impressed at the detail that was available in it. And they did express their infections per 100 months of the patients on dialysis. What they were looking at particularly is multi-drug resistance. That's to say that an organism is resistant to a drug in at least three different categories. They found that there were quite high levels. If you add it up, the total I think is something like 80% of the organisms they found in their trial period, in their observation period, were resistant to multiple different drugs. They then did a sub-analysis looking at whether this is not the rate of infection, because you can see the rate of infection is higher in CVC, but the range of multi-resistant drugs was the same in each group. So it didn't matter whether it was a fistula or line, then you were going to get multi-resistant drugs, organisms, sorry. So how can we reduce this rate of infection? We can see it causes mortality, it's very expensive, and it produces multi-resistant organisms. If we start with the patient factor, this is the beginning of the patient's journey, or should be when we're looking at dialysis patients. And this diagram suggests that the low clearance clinic is there to prevent harm. We don't want the patients banging their head and coming to harm throughout their dialysis journey. So, what is the function of this clinic in terms of dialysis? We need a good run-in to explaining to the patient what dialysis is about, what their chosen modality might be. If they should be for transplantation, we should explore this well up in front in their journey, and we should have definitive access in place by the time we reach the kidney. We're using this now, the kidney failure risk equation, rather than GFR, because GFR is less reliable when you get to 15 or less. So this is the trend now. So why are we pushing for a fistula here? I suspect you all know. The data is very mixed because the population on lines differs to the population on fistula, but I think we'll all agree that mortality is improved and certainly costs are improved if our patient is dialyzing on a fistula. So where did the fistula come from? I've spoken to my colleague Professor Yacoub about this. Everyone commonly knows it as the semina or Brescia fistula, and this is the paper from 1966 where they demonstrated it. They were interns and they had various ideas. They were very fed up with all the access that exists, the complications, the infections, the failure rate of access, and they had to think about what we could do differently. One of them was also a phlebotomist, and he noticed about the higher venous pressures, and they thought that might be enough to drive the dialysis, but it wasn't for long enough. And they spoke with this guy, Kenneth Charles Apple, who was actually a vascular surgeon. And I believe, although there is a lot of information on the internet, but this paper was written by vascular surgeons, so there may be some bias, but they felt that he was the real hero, not Brescia or Semino in this process, that he actually created the first fistula, but it was under their instruction and their direction. Although this occurred in America, they still had a very big problem with creating fistulas, and largely for economic reasons, a lot of patients had AV grafts than AV fistulas, not lines, but AV grafts. So in 2003, they had this Fistula First initiative. Then an unintended consequence of that was, an increase in the number of tunneled lines, because the money had to be made somehow. If it wasn't being made from fistulas, then we'll make them from tunneled lines, is my understanding. This graph shows quite nicely, this is American data from the initiation of the Fistula First campaign in 2003, how the number of fistulas increased. You can see initially, rather surprisingly, that the number of grafts in 2003 outweighs the number of fistulas, which I was quite surprised at, and this is certainly not the case in Europe. You can see that the number of lines, the black one, slightly increased, but then it started to decrease. This was a result of the second part of that campaign, which was fistula first, catheter last, to say that the catheters were there, but they should be the point of last resort. So what are the targets? And rather interestingly, America, as I understand it, do not have a target. It's a patient choice with a leaning towards fistula formation, but they don't set, unless I'm wrong and people can tell me otherwise, any absolute values, which is different to Europe and the UK, and they're slightly different depending on incident or whether they're prevalent patients. But fistula is definitely the way forward. So how are we doing? Now, this is washing our dirty linen in public, I'm afraid. This is Bart's Health data from the same dashboard. And rather alarmingly, you can see that the tunneled lines in red have overtaken the number of fistulas. This is in part explained by the expansion of the program, the increased numbers of what we call crash landers who appear for dialysis literally from nowhere. So even our total of fistulas is not meeting anywhere near our target set by the UK Renal Registry. So this is slightly embarrassing slide, and certainly our surgeons are working very hard to do it. And now how are they working hard to do it, or how are we trying to make a difference? We're trying to ensure that we have a vascular access surgeon at every clinic. This is from GERF, so Getting It Right First Time is a peer review system we have in the UK. And they published this data a little while ago. But you can see best practice is to have a vascular access surgeon, and many clinics do. Does it make any difference? Well, yes, it does seem to, because if they have a vascular access surgeon in the clinic and the patient is coming in a timely fashion to the clinic, that is the top line, then they're more likely, the bottom line, if they come at least a year to the clinic, they're more likely to have a transplant, and they're more likely to start dialysis on a fistula rather than a line. So ignore the bottom line, that's only 61 patients and it's missing data, so just focus on the top 3. What about patient education? It's well recognized that patient education...
5 minutes remaining.
Sorry?
5 minutes.
Thank you. Is an important factor, and we're fortunate from Kidney Care UK that we have excellent resources. There are multiple studies and quality improvement projects that demonstrate that patient education is a key factor in fistula formation and reducing infection rates in dialysis patients. What about the environment that we dialyze patients in? There's a lot of toing and froing in a dialysis unit, people coming and going, staff coming and going. There's a lot of clutter, there's a lot of surfaces. We need to ensure that all of this lends itself to good basic hygiene. There's a lot of waste produced. We need to be able to manage that in both a sustainable and a hygienic way. Now, I went to try and take a picture of one of our dialysis units, and it was just so busy and there were so many faces I couldn't take a picture. But I was restricted to this one here, which is not actually a dialysis unit. This is also a problem we have is with capacity. And this is a section of our ward where we've had to make it into a dialysis unit to provide the slots that we need. And this in itself also causes problems with patient traffic through not only an outpatient service, but through an inpatient service for patients to receive dialysis. We also have problems with clutter in the dialysis unit. These are the day-to-day problems that dialysis units have. We're storing chairs in the corridor, we're storing components in the corridor, and if the infection control people come round, there will be a severe ticking off. Just a slide on the obvious about the prevention against viral infections and the standards that we should maintain, and I'm sure that you're well aware of them and have perhaps more expertise than we do, but they're very well documented, the protocols and the standards. What about the staff? The staff can be a terrible problem with infection, not only the source of infections, but cross-transmitting infections between patients when they put one patient on and take them off and put another patient on. Other aspects of this are listed here. So staff health is quite important, that they're not part of the problem. Communication and safety culture is very important, and I'm just going to come on to that. So safety culture on infection rates in dialysis patients, I think, is really, really important. And if there's a simple thing that can be done to reduce infection rates in your unit, this is probably it. This is a study in America where they had a series of satellite units, and they looked at the infection rate versus the safety culture in each unit. So this picture here shows the 6 different locations, their satellite units, and correlates the staff positive perception of safety through a questionnaire against their infection rates. And you can see that there is a correlation. They chose location 5, maybe location 3 was a hopeless case, but they chose location 5 for an intervention. They had a 4-week intervention, which was fairly basic in educating the staff, reinforcing the basics, ensuring that they were aware of the protocols, and the staff learnt together, and I became more of a team looking after the patients. What was the impact of this? Well, the impact based on that unit was a reduction in the infection rates through simple change in safety culture and staff being invested in the care and mortality of their patients. So coming back to the original paper that I showed you that came from a unit in Pakistan, the answers are already there in the conclusion. Catheter-related infections are unacceptably prevalent among hemodialysis patients in this area of Pakistan, and interventions such as improving vascular access, adopting catheter care bundles, and strengthening staff training are essential to mitigate this preventable complication. And so you already have the answers. I would only add perhaps this antibiotic stewardship. I don't know about here, but in the UK, there's a lot of prescribing of antibiotics on the dialysis unit, down the telephone or whatever, and it becomes impractical to prescribe them often on a evidence-based due to practicalities. So another important part, I think, is to involve your unit in research and development, take part in the audit, present to the rest of the department, so they identify their problems and how they're going to fix them, that they're aware of the issues through the education of your staff, and the safety culture, which I think is a reasonably simple thing to look into. And team working with support. The nurses and the staff are often pushed, they're short-staffed, they don't have enough resources, and it's best to try and support them to get the best out of them for their patients. And at the end of the day, the World Health Organization states that you can reduce the infection rates by up to 50% in the healthcare setting just by washing your hands adequately. And that is my final message. And I think that is worldwide, and we should be doing it more in our units at home and everywhere. It's a simple measure that can save a lot of lives. Thank you.
Thank you very much, Dr. Richard, for extensive and extended coverage of your topics. So, being a nephrologist, we should adopt for the dialysis patient fistula first, because the catheter-related infection and due to that of the cost of antibiotics, so it should be adopted AV fistula first. So, thank you very much. Any question from the audience?
Just referring to one of your slides, in which you said that the tunnel catheters have taken over the fistulas recently. May I know what is the waiting time for creation of a fistula in the UK?
I don't know about in the UK, but in our... I don't know about in the whole of the UK. In our department, we shouldn't have to be waiting. We hope not to be waiting for a fistula, because if they're attending the low clearance clinic for up to a year beforehand, we should have that in place. It's the patients who come, who crash land, who don't have a fistula in place. If you want me to put a figure on it, they may, unless Magdi has got another idea, it's very variable, but I would hope that within 3 months, would you say, Magdi, of initiating, that they would have a fistula. We have a backlog, this is true, we're not very good at keeping up, but yeah, I would say if you make the decision a patient needs a fistula, you can push it through urgently, or I would say about 3 months. What do you think, Magdi?
Thank you.
I think, Ijaz, what is desirable and what is deliverable, there are two different. I would like to have a fistula on the day they come to see me. And now we have got multiple pathways every time our surgeon. Remember, the main thing is that our surgeons like to do transplant. Fistula is at the end of their list. So we do now daycare, fistula, etc., all that can be done. I find it that on an average, depending upon the patient comorbidities, you need 2 hits to get 1 functioning fistula. And it is because of the comorbidities of the patient, particularly diabetics, particularly obese people. And that is the tendency which is now increasing in UK. Our average age for a dialysis patient entering is 65 plus. And when they come to see us, they are in serious trouble. They've got diabetes, they've got severe atherosclerotic artery disease. And I think generally, when we were listening yesterday, when Saeed was saying vein mapping, that the focus among nephrologists is that has he got good veins? We like to protect the veins. We don't want to needle. We don't want to venipuncture on the side which you... That is the traditional thinking. This is what has been drummed in when we were a trainee. I am now realizing it is the arterial disease which determines how good fistula will be. And now the fistula dynamics have been looked at, and they say that it is the dilatation of the artery after fistula which determines how much flow will go through the vein. Whether the vein will develop all depends upon how much the artery will dilate when you have joint vein and an artery. And if your artery is diseased, that will not happen. So that is what you have to upfront recognize, and our surgeons would do a wrist fistula first, which is what we have been told. Wrist, brachial. And there are a group of people who would have a limited life expectancy above the age of 65 with 1, 2, 3, 4 causes which will take them. You won't be surprised if they're not there after 2 years. Should we be aiming for wrist, or we just should get the first site where you can have a fistula? That thinking has just not gone in yet. And second thing is that at least in my practice, I've seen that some of our surgeons have got that ego that he can't do it, I can do it. We need to approach and we need to change from what our practices were in the light of what we see now, what we saw 20 years ago and what we see now. Things have changed. There are a group of patients who would say 680 plus, and I know that he will not be on long. I would just do a good tunnel line in him, and that would be so that will save one fistula. There are a group of patients who have come late, fistula is not yet ready. Should I attempt another fistula or get him a transplant? Those thinking should be doing it, not that because the car is there, I got to use it. Can I go by a bike? And that will be better for me. I think that thinking is not going on because we have become so protocolized, we have become so guideline driven that we just want to do A, B, C, D. We don't think that I can go to D directly and I don't have to go to A, B, C. So it just, I think you would have seen in your practice also that the type of patient you saw 20, 25, 30 years ago and what we see now, they're different, but our approach has not changed. Should we be changing our approach? There are some people which I would quite easily accept tunnel line, as long as what Katie was saying, that we adopt all the practices to, reduce infection in the tunnel line. You're absolutely right. Of course. So there is the data, there is, waiting time is not that. No, you're right. No, I take your point that what it does to the vein, how much stenosis happens, everything what you're saying is right. But the bottom line is that in those group of patients, the deadline for us in our unit is 3 months. So the first dialysis, then the clock is ticking, that they should have a fistula. What I'm saying is that a scar would be given in a week time. When that fistula will be ready to be used, so yes, my surgeon will give me a very good scar. There is a scar, and there is some vein buzzing. When that vein will be ready for me to use. So if you have got a fistula, and that's what Katie was saying, never. So this is what I'm saying, that I'm seeing more and more of those group of patients with all the best intentions. Fistula is not maturing in a better way. That's why in low clearance clinic, we just do the fistula a year before. And we have realized that on an average, 1.5 to 2 hits to get one functioning fistula, so it gives 12 months. So if they are in low clearance clinic, based on the slopes, you can do fistula a year ago. So that is before. We are looking at a group of people who, either in denial, like you, we have got that group as well. They don't want to have dialysis. And at the last minute, fear of God comes, they are still not ready to go to heaven, and they want to live on this earth. So they can do dialysis, stocks up. And those patients then get a neckline. Within 3 months, they should have a fistula attempt. Whether they will have a functioning fistula after 3 months, that is what I don't think so is happening. What is desirable and what is deliverable? Deliverable, I think fistula sometimes are not ready for a year, even though we have attempted.
So sir, thank you very much, sir. Thank you. So we will move forward. Kindly proceed.
Thank you, Dr. Richards. And ladies and gentlemen, this brings us to the end of this session. We sincerely thank our distinguished speakers and chairs and co-chairs for their expertise and practical insights that will undoubtedly inform our clinical practice. It is my honor to invite Professor Syed Munib and Professor Dr. Farooq to present the shields to our respected speakers. I'll invite Dr. Bilal Mohsen to receive his shield. Bilal Mohsen. I'll invite Dr. Tasnuwa Sara Kashem. Dr. Mufti Baligh. Dr. Behram Khan. Professor Katie Richards. Thank you. Ladies and gentlemen, this is now time for the lucky draw as a token of appreciation for your presence. Thanks. Dr. Mateen Akram. I'll invite Dr. Zahid to give the prize. It's just one? This one? Industry we now move to the Industry Symposium by GSK Pharma. I'll invite Dr. Ali Saklan Heather to talk on risk of herpes zoster in CKD patients. Panelists for this session are Professor Noman, Dr. Aisha Ijaz, Dr. Fariha Khalil, and Dr. Harun Ayub. Dr. Ali Saklan, kindly come on the stage for the talk. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. First of all, thank you very much, GSK Pharma, for inviting me as a speaker in this industrial symposium. And I must congratulate Dr. Zahid Nabi and his team, particularly Professor Sajid Abbasi, for conducting this excellent PSN conference in Islamabad. So my talk is today about the risk of herpes zoster in CKD, and this is very important for nephrologists as well, because chronic kidney disease and end-stage renal disease, as we know, these patients have immune dysfunction, so they are on a very high risk for developing or getting this herpes zoster virus. So if you see in this slide, herpes zoster virus is caused by the reactivation of varicella zoster virus, which is the primary infection we all know is chickenpox, and then after reactivation, herpes zoster occurs. But this virus remains latent in neuron ganglia, and it is a very painful virus. As it causes actually two complications. One is post-herpetic neuralgia, and second, if you see, herpes zoster ophthalmicus. And we all know about the PHN, because this is a very painful condition for the patients. The incidence is increased actually in different comorbidities, and particularly we will talk about the association between kidney disease and herpes zoster, and we will see also incidence in renal transplant patients as well. So there are certain underlying conditions like diabetes mellitus, hypertension, chronic kidney disease, COPD, asthma. All these medical conditions can lead to immune dysfunction, and there is a reactivation of the virus. If you see, here are certain, this is an actual meta-analysis which shows there are certain medical conditions like depression, asthma, diabetes mellitus, chronic kidney disease, psychological stresses, and physical trauma. We can much appreciate in chronic kidney disease, the herpes zoster risk, pooled risk ratio is 1.29, which means there is a 29% more increased risk of getting herpes zoster in CKD. And if you see in psychological stress, this actually more gone up to 1.47, means 47% patients with psychological stress or having physical trauma, they are in an increased risk population. So as the comorbidities increased, like diabetes mellitus and cardiovascular disease, like COPD and diabetes and CKDs, these risk for the herpes zoster reactivation actually much more higher in these conditions. And we can well appreciate in the graph that as the age also advances, this risk further increases. And if you see that the patient with diabetes mellitus, with COPD, cardiac disease, kidney disease, they are having much more risk of getting this infection. So this is a comparison of two studies. One study was done in Germany and second was in South Korea. This shows in German population, the risk of young population with underlying conditions was much higher. But if you see in the South Korean population, there the age factor was dominant, and as the age was more than 50 to 51 years to 70 years, there was more increased risk of this herpes zoster infection. And we can well appreciate that in CKD population, 34% more increase was observed in this population. So, as we all know, kidney disease is a global burden, and we have around 850 million people around the globe which are having some sort of kidney disease. And we all know about the diabetes mellitus, hypertension, heart diseases, and family history. These are the common risk factors for CKD. All these conditions like diabetes, hypertension, inherited kidney disease, they lead to actually chronic kidney disease, and ultimately they have the complications like fluid overload, like pulmonary edema, like heart disease. But more important, all the CKD population, their immune system or immune system response weakens as along with the chronic kidney disease. So ultimately, if we see patients with CKD and end-stage renal disease, actually uremic toxins, oxidative stresses, endothelial dysfunction, low-grade underlying inflammation, all this leads to the impairment in the adaptive immune system and innate immune system. And that's why this population having more risk of getting this herpes zoster infection. This is a different meta-analysis in the different part of the world with the different comorbidities. And if we see in all these situations, the pooled risk ratio were much higher in these CKD population. If in this meta-analysis, there were a 28% more risk was present than in another meta-analysis, including the 18 CKD studies that showed 29% increased risk. As we go, all these meta-analyses showed that the CKD population has much higher risk of getting herpes zoster infection. If you see in the different groups of end-stage renal disease, peritoneal dialysis, hemodialysis, all these studies showed that the herpes zoster infection was much more. And even the risk of post-herpetic neuralgia was much higher in this population. So these studies actually show the patient with having herpes zoster and patient not having herpes zoster. This Kaplan-Meier graph very well showed that the gray line shows the patients with no herpes zoster. They have more life without developing end-stage renal disease. But if the patient with CKD has the herpes zoster, that ultimately progressed more faster to the end-stage renal disease, which showed actually that herpes zoster infection also contributes in developing CKD faster to the end-stage renal disease.
Sir, 3 minutes remaining.
This shows
Sir, 3 minutes.
in renal disorders, the risk, efficacy of vaccination was 86%. So the herpes zoster vaccine should be recommended in this population. These are the different countries. Actually, their guidelines recently recommending herpes zoster vaccine in this population, like US, German, Spain, they all recommend the patient should get vaccine in the age of more than 50 with CKD, and particularly KDIGO guideline practice also recommend this. So I will skip slides. This is this is the two major trials, ZOE 50, ZOE 70. Both population in ZOE 50 was age with more than 50, and in ZOE 70 the age was more than 70. All they actually 2 doses 1 month apart was given, and the effect was seen in these patients. This study is actually done in 18 different countries in 219 sites, and results shows there is a 97% efficacy in the age factor from 50 to 69, and if you see the pooled analysis of both studies, the efficacy found to have 91%. In this trial, the recombinant zoster vaccine versus placebo, you can well appreciate that the vaccine efficacy response rate was much better. So, this is a extended follow-up trial which gone up to 11 years, which ultimately showed that the efficacy was 87% in the population, 11 years follow-up with CKD. So in renal transplant, this study design also actually showed that the vaccine response rate was very good against the antigen glycoprotein E within the 30 days. And the patient actually, they have about 80% response rate versus placebo, which actually showed, now I'm getting because of the limitation of time.
You please come to conclusion because
yes.
Experts here, so.
Because this showed all studies that it is a safe vaccine even in a post-transplant patients. So in different side effects were seen, and which ultimately showed that the vaccine response was adequate and good. Summary, that actually vaccine response rate for humoral immunogenicity was 80%. Most common general adverse effects were seen, but these were the temporarily. And if we come in a conclusion, CKD increases the risk of herpes zoster and has herpes zoster complication, including PHN. And if you see pooled post-hoc analysis of the ZOE 50 and ZOE 70, both showed 85% to 97% efficacy rate of these vaccine in underlying conditions. And several countries, including KDIGO, they actually now recommend that the CKD population with underlying conditions, others, age more than 50 should get the recombinant zoster vaccine. Thank you very much.
Thank you very much, Dr. Siklan. I'm thankful to GSK because they brought it here. It's some sort of a thing which we all were looking for as transplant physician. I'm not saying use it in chronic kidney disease. The cost is an issue. But I would like to know the experience of our very senior Dr. Professor Izaz Mand, because sir, ab to vaccine available hai. The cost probably would be an issue. I don't know what is the cost. Cost 50?
It is 45,000 for one dose, and it is a 2-dose vaccine, जो कि first dose के बाद second month, 2 months or 6 months के apart दी जा सकती है. So it is little costly, but the 45,000 for one dose.
You will give one free or no? No? Yeah. Because आपने भी देखे sir, we see a lot herpes post-transplant, a lot of herpes zoster post-transplant. We do vaccine our patients for pneumonia, all those stuff, once we are preparing them for transplant. But probably it was not available. I tried so many times, but now it is available. So for me, for our patients who are from the institution, maybe we can give them very easily. our institution, they does support them. But otherwise, I don't know. But I personally feel that इतना बड़ा transplant हो रहा है तो अगर vaccine हो जाए तो उसमें कोई problem नहीं है. I would like to take comments from Professor Azaz, Professor Jaz, anyone. जी.
I mean, in fact, we have seen full-blown varicella in transplant recipient, and that's where our ID's consultant has started saying that please check their status and vaccinate them. So we are about to start routine vaccination in transplant patient, and they do get very bad zoster when it does occur in transplant patient. And we have experienced mortality with primary varicella in young patients. So I think in our setup, it's probably an absolute must. Yes, I think they have started it. Yes, yes. I don't exactly know, but जिनको के antibody नहीं बनी हुई है transplant से पहले तो उनको सबको दे देना चाहिए. That's what my thinking. Yes. No. Before. After transplant. Yes. Yes.
I would like to ask Dr. Hamad is here because he is from Saudi, all out, so they must be using, or just I want to take his opinion.
Thank you very much. On the recommendations of our infection control department for the last 2 years, we were routinely using this vaccine in our patients and regularly vaccinating all of them, unless there is a contraindication. And it was very well tolerated, and we didn't have any problems. And so it's a routine vaccination now.
So I think
including pneumococcal and all others.
So I think the time has come that we have to adopt it. Maybe I don't know. Saklan can put light on it. Those chronic kidney disease patients who are immunocompromised, as a standard vaccine, on dialysis we do give them pneumonia vaccine. So I don't know how strong the recommendation is for those patients as well. Yeah.
It is recommended in a CKD population, age more than 50 years, even KDIGO now recommends to give them vaccine. In a transplant population, the recommendation 1 month prior to transplantation, but as this vaccine is non-live, so it can be given after transplant as well. I skipped one slide here, which shows actually 1 year efficacy response rate, and that was above the desirable 60% after 13 months. And 2 doses are recommended. There is no follow-up or further doses are not recommended.
First for 6 months. Live नहीं. हाँ जी.
FDA में अब जो लाइव वैक्सीन जो पहले जोस्टर वैक्स के नाम से आती थी वो अब ऑब्सोलीट हो गई है. देयर इज ओनली वन वैक्सीन जो कि रिकॉम्बिनेंट जोस्टर नॉन लाइव है, विच कैन बी गिवन टू ट्रांसप्लांट या इम्यूनोसप्रेसिव थेरेपीज या जो भी इम्यूनो डेफिशिएंट पेशेंट्स हैं उनको ये दी जा सकती है, एंड इट इज़ कम्प्लीटली सेफ फॉर देम. हैंस इट इज़ रिकमेंडेड बाय CDC नाउ. थैंक यू.
Yeah. Before आप probably वो तो देखेंगे आप जैसे CMV का कर रहे हैं बाकी भी. So I think we concluded here by saying that we are all out for it. The cost is an issue. आप थोड़ी कम कर दें तो शायद और बेहतर हो जाए. Because 90 था.
Please reach out to me personally.
Yeah. जी.
Please reach out to me personally for that. We can.
Yeah, because if you can just make life easy for the nephrologist, so probably then we can start it.
We can look into that.
Okay. Thank you very much. It's probably tea break. The faculty they can move on the right side, sir. ये hall के अंदर for the tea break.
For guests, the tea break is across the hall, and please be back in 5 minutes. We'll be starting the next session shortly.
Sound check, 1, 2.
Assalamu alaikum. I'll request all to be seated so that we can begin our next session, please. Assalamu alaikum and good afternoon, respected audience. I am Dr. Hira Ghaffar. I am working as a Registrar Nephrology and PKLI Hospital, Rawalpindi, and I will be hosting this session. So this session is about pediatric nephrology, a field that reminds us that children are not merely small adults, particularly when it comes to kidney disease, diagnosis and management. I will now request our respected chair and co-chair of this session to be seated. This session will be chaired by respected Dr. Professor Noman Tarif. This session will be chaired by respected Professor Dr. Sami J. Khan, and co-chair will be Dr. Professor Noman Tarif, Dr. Aisha Ejaz, Dr. Fariha Khalil, Dr. Humayun Rashid, and Dr. Haroon Ayub, and Dr. Alice Clan Heather. Thank you, respected panelists. Now moving on, I will invite Professor Iftikhar Ejaz, who is currently working as HOD Peds Unit 2 at KEMU Lahore, to give us an insight on differences in the diagnosis and management of nephrotic syndrome in children and adults. This session will focus on differences in the diagnosis and management of nephrotic syndrome in children and adults, a topic which is of high yield and clinical relevance for both pediatricians and adult nephrologists.
Assalamu alaikum, my respected teacher, Professor Hafiz Ejaz Ahmed, sitting right here, sir, chairpersons and dear colleagues, Assalamu alaikum. First of all, I would like to thank Pakistan Society of Nephrology for giving me this opportunity to talk on a very important topic pertaining to pediatric age group and also in adults. I would like to make few corrections, my dear organizer. First of all, I have nothing to declare except that I am a female doctor. और कल जब मैं अपना इंट्रोडक्शन उस पर देख रही थी, पूरी ही के नाम से मेरा इंट्रोडक्शन लिखा हुआ था. And secondly, I was professor at KEMU, but now I am working as professor of pediatric nephrology at Pakistan Kidney and Liver Institute, Lahore. So we will be talking about pediatric nephrotic syndrome and the differences it has with the adults. And main objective would be to go through the diagnostic criteria. Are they different or are they similar in both age groups? What about epidemiology? Is there any difference in clinical presentation? Is the histopathological spectrum varied or is it the same and in all age groups? And what are the treatment protocols currently being used and what is the outcome in both age groups? So let's go to the diagnostic criteria first, which is quite simple, but sometimes it does create challenges, and especially at a junior level, you may get confused. First of all, you have to keep in mind the fundamentally one most important thing is that patient is losing protein and he is losing through the kidneys. So the first and foremost important thing is there are so many other conditions in which you can have proteinuria, but at what level would you label it as nephrotic syndrome? That proteinuria in pediatric age group shall be, if you take in terms of the spot urine protein and creatinine ratio, that should be at least 2 or more than 2. that the protein shall be double the amount of creatinine being excreted at what point in time. The other criteria being used commonly in pediatric age group is according to body surface area, because they are growing object and they are varied in their weight and body surface area that shall not be less than 40 milligram per meter square per hour, which comes to around 1000 milligram in 24 hours time. So once the patient has lost protein, naturally what the next consequence will come into play, he will have low serum albumin, which according to latest IPNA guideline, the level shall be less than 3 gram per deciliter in pediatric age group. And as a consequence of this, obviously the patient will develop edema. So these are the three fundamentally important parameters, and as a part of the disease process, hypercholesterolemia and hyperlipidemia will come into play, which I always tell my students, this is not the primary diagnostic criteria, but it is consequence of the pathological process. If we go to the adult, they should have 3.5 or more grams loss in 24-hour urine. Or if you come in terms of UPCR, that should be 3 milligram per milligram or more than that. Plus again, serum albumin less than 3 gram and edema, same. Now let's go to what is the prevalence globally, and are there any geographical differences? Yes, in children, the global prevalence in different areas is around 10 to 50 cases per 100,000 children, while in adults, it is little lesser, it is around 0.58 to 4, roughly comes to around 3 per 100,000. And you may have around 2 to 7 new cases per 100,000 children per year, and around 3 per 100,000 in adults. Age, the peak age for pediatric nephrotic syndrome is around 2 to 10 years, while the two peaks come in adult age group. The first is at 15 to 19 years, which is basically adolescent age group, and then beyond 60 years for various secondary causes, you can have this. If we come to the sex predilection, it's relatively more common in pediatric age group in the male children, around 2:1, while in adults, it's almost comparable or little more in adult age group in males. While the racial predilection has given us some insight into the different pattern, focal segmental glomerular sclerosis is more common in Afro-American as compared to the Caucasian and European population. While if you come to the adult population, membranous nephropathy has been seen more commonly in Caucasian, while Afro-American again have more focal segmental, and Asian have more propensity toward minimal change and membranous. So what are the causes? Is it really such a simple case? It's not that. You have various secondary causes and you have primary genetic pathology. The genes more come into play. The younger the children, they have more chance of having a genetic component, and this chance keep on decreasing as the person grows, while there are other conditions as well. So genetic mutation, the darker color will tell you that this is more common in podocyte gene in the infancy and early childhood years, while the genetic and syndromal genes, which are basically collagen gene, can be present anywhere and they can manifest with varied manifestation. If we talk about toxins such as the interferon, lithium, and many other chemotherapeutic agents, they almost do play a role in every age group. Infections, similarly, they can play a havoc in every age group. Pregnancy related, obviously, this would come to like middle age when there's a chance of pregnancy. Immunological and circulating factors, little more common in the pediatric age group, but can occur anywhere. And nowadays, there is a lot of talk about the susceptibility genes, but it can increase this phenomena, like a APOL1 gene. They are more common in the adult population. And understandably, the secondary causes like diabetes, like obesity, and many other conditions, they do come into play more in the adult age group. And low nephron mass is a problem more with the pediatric age group. Same is the demographic variation you can see here. And now let's go to the renal biopsy finding. So what is the difference? Generally, we do not do biopsy at the outset in pediatric age group because it has been seen over the decade that 80 to 90% would respond to steroids. And there are 15 to 20%, those are actually focal segmental, but even then they would respond to steroid initially. So it has been seen that it is unnecessary to subject them to this intervention early on. So the first step would be to go to steroid and then see whether is there a need for biopsy. Yes, there are clear-cut indicators. When patient is having congenital nephrotic syndrome, especially less than 6 months of age, or when he is beyond 12 years, because there is a more chance of having secondary causes like lupus, etc., then you go for biopsy. Then the patient, the one who has been labeled as having steroid-resistant nephrotic, whether initial or late steroid-resistant, shall be subjected to biopsy. The one who is having extrarenal manifestation, here comes the play of genetic testing. It's clearly recommended to go for genetic in congenital, in infantile, and with extrarenal manifestation. Frequent relapse rates, steroid dependent. We keep on treating them with steroids, yes, justified. But what? When to go for biopsy? When they are bad in terms of Cushingite features and they are not responding well, you have to keep them on high doses of steroid. There is no point in continuing steroid. Yes, go for biopsy. Take the histological picture and then go for justified alternate medication. When there is a complement level is low, obviously MPGN or lupus can be a cause, and when you need to give second-line therapy. While in adults, it's a logically heterogeneous disease, so early kidney biopsy is recommended even before you start treatment. Renal biopsy nowadays is not required when you have plateau or antibody test positive, because it has been seen that 70 to 80% of them, they are membranous and they will respond probably to treatment as per KDIGO guideline. They have normal EGFR, and especially in familial FACS families where you have characterized mutations, so what the need of going to biopsy, because there are so much overlapping histopathological pattern. So better to go for, immunosuppression stop and then proceed for your supportive treatment. Histopathological pattern, yes, they can give you some clue, but again, there's a lot of overlapping according to actual condition. And here we can see that the age 1 to 6 year, about 25% would be having genetic cause. And this keep on declining as the child grows and become adult, but still there's a little chance of having genetic. Here we can see that the 5 common genes are most notorious to cause this nephrotic syndrome in infancy and early childhood years. So never forget, if you have, now you have relatively cheaper options available here. So always do not be overemphasize the immunosuppressive treatment and go for genetic testing initially, if they can afford. And obviously, if you adults, TRPC6 and ADCK mutations, etc., they are at par. So pediatric histopathological pattern, the first landmark study was actually being driven in 1960s and 70s by international study of kidney diseases involving 521 children, not only from North America, but from European and Asian countries. And it set a benchmark for us that the minimal change is present in 76% of the cases, and around 7 and 6% small percentages were found to be membranoproliferative and focal segmental. But later on, it has been seen in various studies that this pattern does not stop here. It does not only vary with the age group, but over passing year, the pattern are being changed, and we have witnessed them in different studies. One is by Bonilla Felix involving 105 children, and you can see here that focal segmental and minimal change outnumbered. The same study in continuity in the next decade, this number increased even further. Similarly, another study involving 51 children who were steroid sensitive, you can see that minimal change outnumbered anything else, and then this was followed by focal segmental. But here you can see around 231 children being seen, and this published in BMC Nephrology, that IgA nephropathy outnumbered any other condition. And there were other HPS, which is IgA vasculitis basically, and minimal change, and other categories. Now let's see the situation globally. This is data from different countries, including 11 different countries, and total of 806 patients were being examined, which involved more of the observational studies, and only 3 randomized controlled trials were seen here. But we can clearly see that focal segmental outnumbered any other condition, followed by minimal change, mesenteroproliferative, and membranoproliferative, and a small number around 4% was attributed to the membranous one. Now let's see the situation in adults. And you can see here, this study revealed that mesengeoproliferative and MPGN, minimal change, they outnumbered any other category, and then membranous nephropathy, focal segmental, and few other conditions, they came into play. This is data of 632 adult patient, and this is 10-year study. This study being published in Kidney International 2004, and we can see here that minimal change was the largest percentage, but you can see this is group 1, 2, and 3. This is basically pediatric age group. Group 2 is adolescent, and group 3 is adult patient. And you can see the varied pattern. Similarly, a study by Cheng et al. In 2009 from the Korean patients, we can see IgA nephropathy outnumbered any other histopathological category. This is study from SIU to Pakistan, from adult patient, FSGS, and this whole, I will request a few more minutes. So clinical and experimental nephrology reveal us that this was the membranous and focal segmental outnumber, and similarly from Japan and various other countries, we can see. We can see the pattern here. The age rises, membranous, and obviously the focal segmental, but focal segmental come at the halt. It stays at the same pace, but membranous have some rise for some years. Now let's go to the clinical presentation, and I'll quickly go through the differences, because you all know the fundamentally most important is edema. And the first, alarming sign is periorbital puffiness when mother wake up in the morning and mere bachche ki aankhein सूजी हुई hai. So onset is edema, and you can mimic with few other conditions. It's mostly preceded by respiratory tract infection, and our kind of infections are far more common in pediatric age group as compared to the adult one. Intravascular volume depletion and oliguria is more common. They have more propensity as compared to body surface area. So they can thrombose, they can have, volume depletion quickly as compared to the adults. Gross hematuria is lesser, and thrombosis is also less. It's 2.7% as compared to the 24% in adult population. So impaired renal function, hypertension more common in adults, thrombotic complication, hematuria more common. Secondary causes we need to keep in mind, and focal areas of IFTA or interstitial fibrosis tubular atrophy is not only attributed to the focal segmental, because they have other secondary causes, so always keep in mind. Time to remission and response to treatment, the result is different. Respond quickly. They are children. Generally, 80 to 90% do respond within 4 to 6 weeks, while adults, they take longer time to respond. Natural history, you just have to keep in mind about 1/3 or 20 to 30% would become infrequent relapser later on. About 1/3 will become steroid dependent, and same percentage almost will become frequent relapser, and there is an overlap between steroid dependent and frequent relapser category, and about 10 to 15% would be steroid resistant. So just a quick go through what is relapse. When the urine dipstick is 3+ positive or 2+ positive on 2 or more than 2 days, this is relapse. Infrequent, those who relapse less than 2 in 6 months' time. Frequent is those who relapse more than 2 times in 6 months, or 3 or more than 3 times in 12-month period. Steroid dependent, those 2 or more relapses two or more relapses when on tapering doses or within 2 weeks of cessation of therapy. Initial steroid response, those who do not respond in 6 weeks therapy, and late steroid, those who do not achieve remission in 4 weeks in a relapse. Not at the initial outset. Difficult are those who require 2 or more treatments too. Similarly, complicated relapses are the one because of we are short of time. I'll just quickly go through it. Those who are not controlled on the therapy and have a lot of side effects, obviously we have to think about something else. Remission is the resolution of edema, and proteinuria comes to negative or trace. And adult population, almost same definition, so you do not to get worried. So they generally take 16 weeks to respond. Non-relapsing nephrotic are the one, those who will stay in remission for 2 years. Pediatric age group, this definition is clear, but adult is still revolving. Now I would say that pediatric age group has gone ahead of the adult because we have randomized control trial and we have come to a consensus that what should be the actual duration of treatment. Treatment duration is, previously it was thought by ISKD and other group that it should be 8 weeks, 4 weeks daily and then 4 weeks alternate. Followed by other groups, they said that 12 weeks is better because 6 weeks daily and then 6 weeks alternate will be better in terms of less relapses later. In adults, obviously, you need to give bigger doses. ये आगे चली गई स्लाइड, जरा इसको कर सकते हैं आप पीछे. You need to give bigger doses for longer period of time, around 16 weeks, and then decide whether he is responsive or not. पीछे पीछे पीछे. So now we are fortunate, we have 4 randomized control trial, Netherlands trial, पीछे जाइए. कहाँ पे back कहाँ? We have very well designed about 750 or more children, 4 randomized control trial, and which has clearly shown that there is no point in lingering on, given longer courses of steroid, because in terms of relapses or in terms of longer remission, the outcome would be the same. So what we do in pediatric age group now, according to consensus guideline, either he can achieve remission in 4 weeks time, success story, gone, or still we have lost edema, but still some protein 1+ or 2+ is going on, give them 2 more weeks of grace period and see whether they respond. But we will label them as late responder, but they are responder. But no remission within 6 weeks, just tell them that it's not going to respond and we have to go either to second-line therapy for the one who responded either in 4 to 6 weeks, and we have various options for frequent relapser. We can give longer, smaller doses of steroid, less than 0.5 mg per kg alternate day for 9 to 12 months, but not really a very good option. Other good options are levamisole, but in my opinion, this does not work very well, and this actually there is no consensus because European have better response as compared to the other countries. Cyclophosphamide, cyclosporin, tacrolimus or rituximab are the choices. While in steroid-dependent, mycophenolate mofetils, followed by CNIs and retox. Or in steroid-resistant, obviously you get them to the supportive therapy with anti-proteinuric or get them registered in a clinical trial, and those who are partial responders, you can go for the CNIs and continue for 1 year or so. So you are all well versed with the side effects, and I will just quickly go through one more thing, which is membranous. Membranous is clear-cut guideline according to PL2R antibodies and other in the adult age group, but in pediatrics still we have to go around few things. And finally, pooled data and the different trials have shown that the final outcome is almost comparable in all 3 age groups. And take-home message is treatment in the first outset in the children, but biopsy first in adults. Response to steroid in minimal change is almost similar in children versus adults. Relapses are more frequent in children, around 70 to 80% as compared to adult population. Steroid resistance shall be labeled within 4 to 6 weeks, and do not try to keep giving steroid unnecessarily. MCD in both children and adults have good prognosis and good renal outcome. 2/3 of the FSGS, they do go to remission, either complete or partial. So complete remission is more common in children as compared to the adults. About 15 to 20% of the children will keep relapsing in the adulthood. So be ready to treat their relapse, and thank you very much for your patient listening.
Thank you for translating complexity into clarity and reminding us why age-specific approaches matter. We will now welcome brief question and answer sessions from the audience.
Excellent presentation.
Thank you, sir.
I just wanted to know if you ever use SGLT2 inhibitors in addition to the curative therapy as an antiproteinuric.
in children?
Sir, actually, to my knowledge, it has not been used anywhere in the world, and there are no trials on SGLT2 inhibitors. But for refractory and difficult cases, like occasionally we do use obinutuzumab, and patient showed some response, and there is some literature available on the use of ubino, while rituximab is being used commonly. Thank you.
Next speaker, would you announce, please? Thank you.
Thank you for this wonderful talk. Moving forward, we now transition from pediatric nephrology to pregnancy and kidney disease, shifting focus from early life renal disorders to the unique challenges of kidney disease during pregnancy. I now invite respected Dr. Professor Izaz Mand, who has served as HOD nephrology at Sheikh Zayed hospitals for 5 years, to give us some insight on pregnancy in advanced CKD and dialysis, outcomes, ethics, and practical management.
Bismillahirrahmanirrahim. Thank you, Professor Zahid Nabi and his team, for inviting me, and congratulations on doing such a wonderful conference and giving us all the opportunity, particularly the junior colleagues, to enrich their knowledge from this. I will start my talk with paying tribute to these two mentors. I think without their names mentioned in this conference, we will not be doing justice. Professor Jafar Naqvi, you heard about Professor Adib Rizvi, who paved the path of transplantation and established SIUT, doing a world-class level work. But in the field of nephrology, Professor Jafar Naqvi in the 70s established the first nephrology unit in JPMC Karachi. And then in 1986, when Sheikh Zayed Hospital was commissioned, where I had the honor of serving for over 20 years, Professor Tahir Shafi, my mentor, whom I spent more than 40 years together, he was my teacher, my friend, my brother, my father, and a senior colleague. He established nephrology in Sheikh Zayed Hospital in 1986, and this center became the main center of nephrology training in Punjab. And most of the heads in Punjab in nephrology are all products of Sheikh Zayed Hospital. I must make dua for them that may Allah Ta'ala give them, highest place in Jannah. And at the same time, I must say that they played a very crucial role in establishing the foundation of nephrology in Pakistan and paved the path for the youngsters to take that path. And they enhanced the academics and the research in the 80s and 70s and 90s and beyond. Next, please. कैसे आगे होती है? Okay, I will just be covering the prevalence of pregnancy in kidney disease, advanced kidney disease, dialysis patients, and hemodialysis versus peritoneal dialysis, the management and the outcomes of these pregnancies, the role of contraception, ethics, and the pregnancy after transplantation. I'll just touch upon it because Professor Tasaddaq after me is going to elaborate more on pregnancy after transplantation. So pregnancy, as you know, in the advanced kidney disease is a big challenge. The dialysis takes care of most of the aspects of kidney failure, but it does not completely look after other aspects like
fertility. And if the fertility is markedly reduced, but it is not absence. And there is a chance of 1/100 of getting pregnant as compared to the young general population. Unplanned pregnancies do occur, and contraception counseling is essential. Pregnancy outcomes have improved dramatically over the last 5 decades and increasingly feasible with modern care. Live birth rates and gestational age are increasing because we know that these two are major problems if there is a successful pregnancy. But we have to intensify the dialysis. If you look at over the years, over the decades, how the Australia, New Zealand data has reported that from the 70s to 80s to 90s to 2000s years, the prevalence has increased amongst these women. And if the patient is younger and is in CKD, advanced CKD, or on dialysis, then the chances are much more in terms of success of pregnancy. Certain criteria, like the outcome will be better if the serum creatinine is less than 2.5, or if the proteinuria is not massive, less than 1 gram, and the blood pressure is well controlled, and there is absence of systemic disease like lupus nephritis or vasculitis. So in these, the chances are better. And in a survey of 2,364 pregnancies, it was found that hypertension was present. Those who did not have pre-pregnancy hypertension, the prevalence of hypertension was 7.7%, 11.9% preeclampsia, and HELLP syndrome 0.7%. What are the maternal risks? The accelerated CKD progression. That means if they are in CKD3, they have a chances of going into CKD4, and if they are in CKD4, they have a chances of going into CKD5 or on dialysis. Anemia gets worsened, and volume overload becomes a problem. What are the fetal risks? Miscarriages, very common. Live birth rate, not more than 40-50%, but with intensified dialysis, it has improved to 86%. Preterm birth, majority of these women who with advanced CKD become pregnant, they are advised to have a delivery around 37 weeks. It's not carried beyond that. And preterm birth is very common. Intrauterine growth retardation, low birth weights, again very common, 45%. And there is a need of neonatal ICUs because these babies who are born, they require support. The congenital anomalies are more or less the same as in the general population, unless there is a history of aneuploidy. Now, when we look at the eGFR, it is not reliable because the normal physiology of pregnancy, just like the blood pressure falls in the first trimester in normal women. If a woman is normal, and if has a blood pressure of 110/70, in the first trimester it will fall to, let's say, 100/60 or 90/60. This is physiological. And in the mid-trimester, it comes back to normal, and there are risks of increasing in the third trimester. The same holds true for the eGFR. Because of dilution and other factors, the eGFR is not reliable. So staging these patients, whether they are in CKD3 or CKD4 or CKD5, you have to rely on the pre-pregnancy GFR. The loss of kidney function after they become pregnant. Now, higher is the grade of CKD, more are the chances of further losing the GFR. And you can see the pre-pregnancy, during pregnancy, and after postpartum, there is a decline, and more so in the CKD4 and 5 as compared to CKD3. The outcome of pre-pregnancy CKD stage, again, you can see that I think this pointer is not working. If you look at the gestational age, Yeah, okay. That in CKD5, the delivery occurred in 40% before 34 weeks and in 20% in CKD3A. Similarly, the birth weight was 10% below the third percentile and 40% below the third percentile. And the fall in GFR or need of renal replacement therapy after 1 year post-transplant was 33% in CKD3 and 90% in CKD5. So these are the parameters or the considerations factors when we advise about pregnancy or a woman who wants to conceive and is suffering from CKD. Now, this is a retrospective cohort study from 2003 to 2017, and these are 6 specialized centers in the UK from where this data was taken. They were all CKD3 or 5, and 178 pregnancies, and you can see the division CKD3, A, B, and 5. 79% of them had chronic hypertension, and 46% of them lost 25% of the GFR after the pregnancy. If we look at the outcomes, the 26% deliveries were prior to 34 weeks of gestation, and 36% had low birth weight. Now, about patient on peritoneal dialysis or patient on hemodialysis. We know that peritoneal dialysis is not done as frequently as hemodialysis is done. So therefore, the number of pregnancies occurring in these patients is quite, apart. About 150 to 200 pregnancies have been so far reported in the literature occurring in patients undergoing peritoneal dialysis, and around 15,000 pregnancies have been reported to date in worldwide. Of course, there are various studies, various surveys, and because of scarcity of time, I've just made one slide out of those to give you an idea. The proportion of dialysis pregnancies, 5 to 10% in peritoneal dialysis, and more than 90% in hemodialysis. Live birth rate, more or less similar. Preterm delivery, very common in peritoneal dialysis, and improved with intensive hemodialysis. How we are going to dialyze these women, I will discuss that. Polyhydramnios, less common in peritoneal dialysis because you are doing a more stable dialysis. The osmotic load is less, so the fetus is producing less urine. And therefore, because the urea and creatinine and these osmotic things are under control in peritoneal dialysis because of a continuous thing. And it is common in hemodialysis. The dialysis adequacy, it becomes inadequate because the uterus is enlarging and occupying the space in the belly. So either you increase the dwell time or you increase the number of exchanges or you increase the peritoneal dialysis. And in hemodialysis, it can be easily increased from 3 sessions to 4 sessions to 5 sessions or 6 sessions a week. And the technical issues, there is problem in filling, and there is problem with the catheter can dislodge or it can get entangled. There may be leaks, and hypotension can occur in hemodialysis, or repeatedly puncturing these fistulas can produce access issues. And most of these patients need to be switched from peritoneal dialysis to hemodialysis because of these factors. Now, if a woman wants to conceive and is in CKD 3, 4, or 5, because you can't deny her the right to conceive, and preconception, what is your duty? That you discuss with the family that how they want to plan their family. If they have 6, 7 children already and come from a low income group country, then you have to, counsel them that what will you do with the next baby, because you already have. But every woman has a right to conceive because they think that they are useless if they are unable to conceive and they have no children.
So the timing has to be discussed, the outcomes of that pregnancy have to be discussed, the loss of GFR that is going to happen, or the need of dialysis if they are not on dialysis already. And then we have to stop all the teratogenic drugs like ACE inhibitors or like angiotensin receptor blockers, or if the patient is on immunosuppressants for a CKD, like mycophenolate mofetil or everolimus or tacrolimus or sirolimus, then you have to stop these drugs because tacrolimus, by the way, is safe, but you have to switch to other drugs. And then you have to do the monthly pregnancy test because periods are not reliable and not regular in these women, and they may not know when they become pregnant. And you have to establish right at the outset, you have to establish a multidisciplinary care of nephrology and obstetrics and neonatology, and you have to take everybody on board. In the first trimester, you have to intensify the hemodialysis to 36 hours per week. And then you have to do the labs every 2 weeks, you have to dialyze these patients. The dialysate has to be modified. You have to keep the potassium between 3 and 3.5, you have to keep the bicarbonate around 25, so you have to alter the dialysate. And you have to give aspirin to prevent preeclampsia. It is used to prevent preeclampsia. You have to adjust the weight, because weight becomes a problem. You can't go to the same ultrafiltrations because we have to allow 0.5 kilogram per week increase in weight because of the growing fetus. And you have to use the ultrasound. All this is carried through in the second trimester. At 20 weeks, you do the anomaly scan, you do the biparietal diameter, you look at the growth of the baby, you do the umbilical artery Doppler to see if the flow is fine, or you do the fetal monitoring, and you do the placental Doppler, and you screen for preeclamptic toxemia and do LFTs if the patient complains of hypertension, pain in the right hypochondrium, etc. And the dialysis prescription, how you change it, you can go to the nocturnal hemodialysis. And patient can do 7 to 8 hours nocturnal sessions. Or because your target is to keep the blood urea nitrogen less than 35 or blood urea less than 50 milligrams. That's your target. So you do 6 sessions per week. You change the potassium, the bicarbonate, the calcium in the dialysate. You use low-dose aspirin to prevent this, and you use biocompatible dialyzers, and you allow the weight gain. And you give more calories. You give 35 kilocalories per kg, and you increase the protein intake from 1.5 to 1.8 gram per kg in order to allow for pregnancy to continue. In peritoneal dialysis, you intensify, or you can go on to the cycler and reduce the dwell time and volume and do multiple exchanges. Or you can leave some fluid in the belly for the tidal dialysis, because with growing baby, there will be a drain pain in the patient when the belly is being completely emptied. And you advise lateral decubitus. These are the drugs you are all familiar, antihypertensives, which are safe, which you have to stop. The steroids can be given, CNIs can be given. Azathioprine switch, HCQ is safe. MMF, mTOR inhibitor, cyclophosphamide, contraindicated. You have to give EPO, iron, and you have to, these are, by the way, we discussed today, the HIF agents, these are contraindicated. And the cinacalcitant, sevelamer is also contraindicated. You can use calcium carbonate. And calcium acetate is not recommended. And you can use calcium-based phosphate binders, calcitriol. And warfarin and anticoagulants are contraindicated. Heparin is allowed. And you have to double the dose of water-soluble vitamins because of increased loss in hemodialysis and peritoneal dialysis. So in the third trimester, you intensify dialysis, keep the blood pressure below 140/90, but avoid hypotension. And at the time of delivery, you should try to induce it by 37 weeks. And you should ensure the availability of neonatal ICU. You can do a heparin-free dialysis at the end allow for the parturition.
And you have to adjust the magnesium because some women will require magnesium for preeclampsia. And magnesium, if already is high, can be toxic. So you have to adjust the magnesium. And vaginal delivery is preferred unless there is a compelling indication for C-section. Postpartum, you have to support the breastfeeding. You have to take care of the medicines which are excreted in the milk. Losartan is safe. If the patient has to go back to antihypertensive, you can use losartan. It is safe in breast feeding, but other ACE inhibitors, ARBs, are not. You have to review the medication. You have to resume the pre-pregnancy dialysis regime, and you have to watch for depression, with postpartum, so on. Now, a few words about the predictability of a good outcome. How do you predict that it's going to be a good outcome? Maternal factors, age, smoking, weight, etc., diabetes, prior history of trisomy, stage of CKD, mean arterial pressure, proteinuria, other comorbidities, uterine artery Doppler, and then certain blood biomarkers, which is the ratio of this SFT, SFLT, tyrosine kinase inhibitor 1, and the placental growth factor ratio. These are calculated. If the ratio is high, then there are more chances of a bad outcome. And if the ratio is low, then it is going to be a better outcome. And fetal, of course, you do all the scans, and in the scans you do the nuchal transparency, and you the nasal bone and echo, and the Foundation of Family Medicine has made a scoring system in which they add up together the nuchal transparency, which is, by the way, for trisomy 21, trisomy 13, trisomy 18, and the nasal bone, and you do the ductus venosus and tricuspid regurg echo, beta HCG levels, and plasma proteins A, and you add them up, and there is a scoring system, and according to the score, you have a mild risk, moderate risk, or a high risk. Now, this is an example of a patient who was ANCA vasculitis and rheumatoid arthritis. This was published in October 2025. And this patient was taking rituximab for rheumatoid arthritis and was now in remission from ANCA and had reasonable control. His medicines were then changed, and the patient had an unplanned pregnancy. She became pregnant. Her losartan was stopped, and this rituximab was stopped, and she was put on labetalol and nifedipine, and her creatinine was 2.2, and hemoglobin 8.9, and minimal proteinuria 0.5 grams. And at 32 weeks, she was admitted because of intrauterine growth retardation and worsening kidney function. Creatinine crept up to 3. ANCA serology was still negative, proteinuria worsened, and at 32 weeks of gestation, she was put on hemodialysis now. So you are not waiting for the symptoms to occur. She was put on hemodialysis 6 days a week for 5 to 6 hours, and she developed eclampsia on top of it, and then uncontrolled blood pressure. So the labor was induced at 34 weeks and resulting in a vaginal delivery with favorable maternal and fetal outcomes. But postpartum, she was discharged on 4 days per week dialysis and planned for PD and then planned for renal transplantation. So this is all possible. So when we talk about ethics, these are the certain contraceptive measures. They carry the risk of venous thromboembolism. If you put them on estrogen, progesterone, you can give injection. You can do a permanent sterilization if already has a family. You can insert an IUCD, so on and so. Each has pros and cons. Now, when we talk about ethics in pregnancy and transplantation, the expert and champion of ethics is sitting in front of me, so I don't know how can I talk about. But then there is a psychosocial aspects. The pregnancy is important to 74% women in CKD. And there is a reduced self-worth if unable to conceive. So we cannot deny the right of becoming pregnant. Family, work, graft loss, exacerbating disease, fear of birth defects, and immunosuppression, all of this has to be considered before at the time of counseling. And decision making has to be mutual, control and determination, risk of pregnancy, trauma, when physician unduly warn against pregnancy. Patient may come to you and say, oh, no, you are on dialysis, you have CKD5, you will die. You should not get pregnant. Now, in 1975, in the Lancet, this article was published. And here you see, it says, children of women with renal disease used to be born dangerously or not at all. And many women disobeyed their doctor's orders with a happy result. So this is 1975. So when you are caring for pregnant patient with CKD, there is a duty to the patient, the preconceptional planning we all discussed, the duty to the fetus, you have to avoid fetotoxic drugs. If you have to terminate the pregnancy or if at some stage it is required, or if there is aneuploidy, or you have some other major birth defects, you have to terminate, you have to take the patient in counseling. And duty to the healthcare system. So shared decision-making models combines with the patient's value and social context with medical considerations. And of course, you cannot, you have to be compassionate. You have to be on the patient side rather than on the scientific side, and it should be without any maleficence. And if a baby is born from a mother who has a reduced life expectancy, so are you doing an injustice to the baby, that the baby is born and mother will go in? So again, you have to discuss that who will take the parent's place when she has to go. Will the father take the parent's place alone and will manage this child? So these are ethical issues and these should be discussed, but you have to be compassionate and listen to the patient and sit with them, have long discussions, and then plan the pregnancy. The pregnancy after transplantation, 36 years ago, in 1994.
Sir, actually we are running out of time.
Just last slide. We published from Sheikh Zayed this success of 4 pregnancies in 3 patients. And this was the first report of pregnancy after transplantation. I did this 32 years ago. And now I am sure there would have been some publications from there. So my last slide says that women with CKD can become pregnant. Hypertension is universal and proteinuria worsens. The decline in GFR can worsen in pregnancy. Autoimmune flares can happen. Growth retardation, prematurity is common. Maternal mortality is not high. Contraception is essential. Dialysis intensification is mandatory according to the KDIGO guidelines. All that I have described, the modification of dialysis prescription, it's all in line with the KDIGO guidelines. And it requires multidisciplinary care, maternal fetal medicine, neonatology, and there is a risk, and it increasingly becomes feasible with the modern care, and responsibility for increased research and public debate. Thank you very much.
Thank you, sir. Thank you for balancing evidence with empathy. Both are essential in these cases. Moving forwards, successful transplantation restores fertility, but pregnancy introduces new complexities. This session, the next session, will guide us through safe navigation. I will now invite Dr. Muhammad Tasadduq Khan, who is serving as a chief transplant nephrologist at Dow University Hospital, to present a talk on pregnancy after kidney transplantation, graft safety, and maternal outcomes.
Assalamu alaikum, and thank you very much, PSN, for giving me this opportunity to present myself and it's a great honor to present in front of all the mentors and senior fraternity of nephrology. So today my topic is pretty difficult and pretty easy as we live in Pakistan. So हमारे यहाँ दो चीज़ें very important, शादी हुई कि नहीं हुई और फिर बच्चा हुआ या नहीं हुआ. This is very important. जब तक अगर ये चीज़ें नहीं होती तो society को भी सुकून नहीं मिलता है. So let's start that transplantation and pregnancy एक बहुत like it's a kind of thing that majority thinks that pregnancy is not possible after transplant because transplantation has been done with a very in a way that families have suffered a lot, so they don't want to go into that. But as we were discussing, we are living in Pakistan and we are still in the process of developing things, and we are developing in a right direction. And it is all about shared decision which we have to move forward. So today we are going to discuss, these are the learning objective, what we are identify ideal candidate, timing for conception after kidney transplantation, evidence-based immunosuppression. That is the most important thing, that what's and how you are going to interpret it and how you are going to settle your patient, recognizes and manage key complication, which Sir has already told about you, and compare outcomes and data from South Asia versus developed nation. Why this matters clinically? Clinical reality, fertility often returns after successful kidney transplant. So in our population, if you don't counsel, if you don't discuss, you come across with unplanned pregnancies are common. Despite the fact that they are aware that this is a kidney transplant recipient, but you must have seen there are few patients coming up with unplanned pregnancy. So pregnancy in kidney transplant is high-risk obstetrics plus high-risk nephrological complication can occur. Outcomes are usually good when planned and graft function is stable. That is the most important thing where the transplant physician has an important role, because these patient belongs to transplant physician. So it is all his or her domain to counsel and to prepare your patient. Counseling gaps always remain prominent, and that need to be addressed. So infertility, why this infertility in CKD, Sir has already discussed, is just a hypothalamic pituitary gonadal axis disruption, anevolution, hyperprolactinemia. These are all things which happen, decreased GnRH, LH surge nahi hota, anevolution, hyperprolactinemia, which suppresses GnRH, altered leptin and insulin signal, thyroid dysfunction may contribute. Chronic inflammatory condition, CKD, oxidative stress, affects ovarian function. So anemia, hypertension, medical effects, some antihypertensive are teratogenic, which we already discussed. So these are the things which happens in CKD, erectile dysfunction in men, impaired sperm health, hormonal issue. If we see in the women, hormonal imbalances, menstrual irregularities, reduced ovarian reserve and low libido, and sexual dysfunction. Impact of dialysis on fertility and ovulation is common. More than 70% of women on dialysis are anovulatory because of the anemia and other several hormonal factors. And sexual dysfunction, decreased libido and pregnancy. This what the hemodialysis has to offer. Sir has already gone through with all the details. Getting a pregnancy in hemodialysis is a bit difficult as compared to the transplant, because the patient has to go on intensifying the hemodialysis for 36 hours a week is too much for the patient. So this is difficult, and if the patient gets pregnant during hemodialysis, she has to suffer a lot. But after transplantation, why fertility returns? Because rapid clearance of uremic toxins, prolactin and sex hormones improve over months, improve nutrition, persistent CKD, hypertension and immunosuppression still shape pregnancy risk. Comparison, if you compare it with the hemodialysis and transplantation, so you can easily see that transplantation got an increased risk, increased numbers as compared to the hemodialysis. This we already discussed. So what are the key outcomes? Live birth is common after kidney transplantation, but complications are frequent. Systemic review have been done across the globe, and which shows live births 78%, pre-eclampsia 21%, preterm delivery 45%, C-sections 69%. So developed nation, what their data showing 79% live birth and kidney transplant recipients, but still 50% are preterm among live birth. Key drives for preterm drug-related hypertension and impaired renal function. So maternal risk compared with general population, pre-eclampsia risk markedly higher than in general population, and preterm and low birth weight higher as well. Meta-analysis in transplant recipient shows increased odds of pre-eclampsia, preterm birth weight, low birth weight, rejection, and graft loss are less common but important. So, core principle, what we are going to do in transplantation. Number one is the medication, which we already discussed, what drugs are teratogenic. So you have to switch it. So if you are given an option and you are aware that your patient is young and she needs to get pregnant, so counseling should be done earlier because it should be a planned one. So medication switch should be done at timely because at least 3 months time is required to switch teratogenic medication on safer drugs. Vital screening for infections, update vaccines, and antenatal care. It should be a multidisciplinary team which should be dealing with these patients. So what KDIGO say, it says wait for 1 year post-transplant, stable function, proteinuria less than 1 gram per day, and UK renal pregnancy guideline usually says more than 1 year and stable function on pregnancy, safe medication. And practical 12 to 24 months is commonly used when risk factor exists, but it has to be individualized. See your patients, how she's doing, and what are the social circumstances, what are the ethical factors which you need to consider when you are discussing this pregnancy issue. What are the ideal candidate? The green light when the stable creatinine, EGFR is normal, minimal proteinuria, aim low, BP controlled on pregnancy, safe agent, no rejection in last 6 to 12 months, stable immunological risk, diabetes optimized, and patient is reliable and patient is following you religiously. That is very important because in our society, patient loss to follow-up are very common in post-transplant, and that is the main reason for rejections and other infections. So what are the contraindications? Recent acute rejection, unstable DSA risk, rising creatinine, significant proteinuria, active GN recurrence, uncontrolled hypertension, teratogenic immunosuppression, not yet transited, active infection, CMV, BK, or untreated cervical disease. Contraception, until ready, contraception is not optional, so they should be well educated and they should be told that we will be changing your medication once you have planned, and you have to inform us before planning. Till that time, you should use contraceptive measures because unplanned pregnancy will never give you time, and patient come up taking MMF in the second month of their pregnancies. So counseling gaps should not be there. What is compatible? Common pregnancy compatible backbones, CNI, tacrolimus, cyclosporin, azathioprine, prednisolone, safe, and monitoring is crucial during the pregnancy. Tacrolimus and cyclosporin levels drop by 50% in pregnancy. So that is the most important thing which transplant physician need to see, that he has to increase the dosage of tacrolimus and cyclosporin. Along with that, it is recommended that initial slight increase in the steroid dose, but in the later trimester, in the third trimester, you should increase your steroid religiously. And mechanism increase, why we need to do that? Because of the increased volume of distribution and increase GFR, management check levels, monthly dose increase of 20 to 50% are often required. So this we have already discussed, mTORs and MMF we should not be giving. It should be stopped 3 months prior to planned pregnancy. It is important. And if on MMF, we have to switch them on azathioprine. And paternal exposure, this is very common. What I have seen that majority of the nephrologists usually tell that paternal exposure also increases the risk, but it is not there. Does the father medication affect the fetus? What do you think? It is not. So that we need to take this message from here that paternal exposure does not cause anything. mTOR and MMF have theoretical risk, but the national guidelines or international guidelines doesn't say that you have to stop them. So recommendation most certain, do not require fathers to stop MMF, but counseling is advised. Preconception labs, these are all basic labs: creatinine, EGFR, urine, PCR, ACR, urine analysis, electrolytes, immunological. If your patient is highly immunological risk or desensitized, as desensitization has been done, so DSA, history of rejection, metabolic, HbA1c should be controlled, lipids, thyroid, infections, CMV, hepatitis, HIV, syphilis, urine cultures, if recurrent UTIs, which is most common after transplant, pap smear if indicated, and vaccine should be done. In the first trimester, confirm date, adjust medication, baseline labs, treat bacteriuria. In second, monitor BP, TAC level, increase dose, anomaly scan at 20 weeks. Third trimester, weekly visit, fetal growth scans, and planned delivery. Multidisciplinary care model should be there: transplant nephrologist, plus fetal-maternal medicine, plus obstetric anesthesia and neonatology. And clear escalation triggers and shared plan should be there. BP thresholds should be set, proteinuria, creatinine change, suspected rejection versus preeclampsia pathway, delivery planning, and transplant surgical awareness as well. Because if she's going to have a C-section, then the transplant surgeon should be informed on that day, because if there is any complication, he should be ready for, should be on board. So monitoring is casual, labs at least monthly, often more. Creatinine, electrolyte, urine TAC levels should be frequently done. Fetal survival surveillance should be done. Hypertension management, avoid severe hypertension, reduce preeclampsia and preterm triggers. Common pregnancy safe mode: labetalol, nifedipine, methyl dopa, which we already discussed. Avoid ACE, ARB. Preeclampsia prevention, we have to use aspirin in all the patients. And baseline proteinuria is common. Rising proteinuria could be a mean of preeclampsia, rejection, or reoccurrence. This is the point where the transplant physician should be very clear, okay, what it is. Is it a preeclampsia? Is it a rejection? Or is it a reoccurrence? Because you have to go through once at least for PCR or ACR, and if it is rise, then you go for 24-hour urine for protein. Both can present with the same rising creatinine and hypertension, proteinuria, rejection, immunological risk, plus graft loss risk. Preeclampsia, maternal fetal morbidity, delivery may be definitive. Treatment differential guidance emphasize on transplant pregnancy literature. Stepwise approach should be confirm adherence, drug levels, evaluate hemolysis, platelets, LFT, uric acid. These are all preeclampsia features. Urine sediment, culture, ultrasound, and if obstruction concern, consider angiogenic markers, which we have already discussed. Biopsy only when results will change management. So there is no point that we should be doing biopsy in a routine. Acute rejection, if it happens to have, if you get a rejection during pregnancy, then treatment would be only steroid, which is safe. Biopsy, it should be individualized. If you really think that patient might help in with the result, if feasible, until 28 to 30 weeks, risk of bleeding and uterus injuries is there. CMV And herpes is very devastating. Primary CM infection during pregnancy is disastrous, and reactivation risk is manageable. Valgan cyclovir generally avoided teratogenic. In this case, use high-dose acyclovir or IVIG if necessary. This we already discussed. Infection prevention, asymptomatic bacteriuria and UTI risk increases, low threshold to screen, and CMV, BK monitoring as per center risk, vaccine, influenza, Tdap, and during pregnancy, per obstetric schedules need to be done. Diabetes should be well controlled, and tight glycemic control should be there in order to avoid the complications. Anemia and bone mineral issues we have already discussed. It's the same what we can use in CKD and hemodialysis. And delivery planning, what nephrologists should be knowing. Mode of delivery, obstetric indication plus maternal preference. Kidney transplant alone isn't an absolute C-section indication. ये हमारे यहाँ बहुत common है कि we always tell that it's going to be a C-section. वो वैसे it's like more commonly happen in obstetric population in Pakistan, but they can be done vaginal deliveries as well. Inform surgical transplant team for delivery planning, location of graft, incision consideration. Anticipate higher C-section rates in real world data. Delivery consideration, mode of delivery, vaginal is preferred, C-section only for obstetric indication, and surgical warning care must be taken to avoid the allograft, usually in the iliac fossa. Transplant surgeon should be on call. Postpartum, high risk window. Postpartum care, the crash creatinine may rise transiently. Postpartum, what happened?
2 minutes.
Just 2 minutes. Drug levels, tacrolimus levels will spike post-delivery as distribution volume normalizes. Rapid dose reduction required, 20 to 25. Breastfeeding, it excretes in breast milk, but it is safe. It doesn't cause any harm. Data, I will just skip this slide and discuss this slide. Data from developed nation, US versus Indo-Pakistan, mean maternal age are quite similar, Indo-Pakistan a little bit less. Unplanned pregnancy are higher in Pakistan. Donor source are live and there are deceased. Low birth weight, very common in our society. And this is our data, number of pregnancy, 8. Donors, 38, mean age were 27 to 32, and preterm were 3, stillbirth were 1, 5 C-sections, and 3 normal vaginal delivery. And donors का data भी है. Practical interpretation, हमारे पास, like we have done 2-3 studies, one by Dr. Ahad, SIUT by Dr. Rubina, who is sitting in this audience, and she has done, and which shows that the unplanned pregnancies are common. I think I have lost that slide. But our data, only 3 studies have been done, and pre-conceptional counseling was never done in majority of the patient. That is the important thing. Practical interpretation in Southeast Asia, regional guidelines, I will just skip. So clinical workflow, 1 slide blueprint, women transplant pregnancy pathway, identify women of reproductive age at every visit, counsel, conception, pregnancy planning at baseline annually, preconception checklist, kidney, BP, proteinuria optimization, and rapid access pathway for positive pregnancy test, and joint nephrological fetal-maternal medicine clinic slots for every 2 to 3 weeks. Take-home message, fertility improves after kidney transplantation, but pregnancy remains high risk, best outcome results, timing more than 1 year, medication safety, stop MMF and mTOR before conception, structure multidisciplinary care, Southeast Asia, better counseling coverage plus local registry. Thank you, and if you have any questions, I'm happy to answer. Yes.
Very important topic. First, of pregnancy in transplant patient. one of our colleagues at Quaid-e-Azam International Hospital told me about illness of her daughter. She was transplanted in Quaid-e-Azam International Hospital. Donor was from the family. And for next 1 year, everything was okay. Blood pressure was normal, creatinine was, she was slightly overweight. Otherwise, blood pressure, protein, urea, everything was okay. Then she left for Australia. And after 6 months, roughly after 1.5 years, they contacted me, my colleague, that they want to have a baby. And Australian nephrologist is not allowing. It's not possible to have right now. So he asked me what to do. So I told him all these things which we have written, tell him. The reply was, give in writing. So on my pad, I gave in writing. The next reply was, write down references. And I wrote the references about, more than 1 year, 2 years up to this, everything. Creatine is normal, blood pressure is normal, everything is normal. And then he finally agreed. So it's not, most of people are, reluctant to take risks. And on this December, she came on holiday and she has got 2 beautiful kids.
MashaAllah.
Regarding dialysis, ji?
Was it twin pregnant?
No. मतलब time, twin nation after one after other. Okay. So, regarding dialysis during pregnancy, I think your case was ANCA-associated vasculitis involving kidney. Probably the ANCA was negative throughout. But were the patient on some low, because what I have seen is that you have to put some at least immunosuppression even when it's 1 or 2 or 3 years. Because normally it is written 1 or 2 years, but my experience and the experience of the Hammersmith group, I discussed with them, is that you have to keep very small dose of immunosuppression, maybe very little, 1-2 tablet. तो आपने कंटिन्यू रखा तो वो क्या था ड्यूरिंग दैट पीरियड नहीं एग्रीड कुछ लो डोज इम्यूनोसप्रेशन रखी कि नहीं नॉर्मली तो एंका लेट से अगर वो है नेगेटिव है थ्रू आउट और 2-3 साल गुजर गए हैं तो बुक्स तो ये कहती हैं ठीक है
Can we have this discussion in the lunchtime, please? Because we are already gone far beyond the time.
Okay,
Thank
sir.
you very much. So nice of you.
Thank you.
Next speaker, please.
Thank you, Dr. Tasadduk, for a wonderful presentation. Thank you for a wonderful presentation.
Thank you for the practical insights and outcome-focused discussion. Moving on, preeclampsia is more than hypertension. It's a systemic disease and renal disease with lifelong implications. I will now invite Professor Dr. Zahid Rafiq, who is working in Services Hospital Lahore, to give us a talk on hypertension, preeclampsia and the kidney beyond the blood pressure control.
Thank you. So far what I have seen is that there are excellent talks by Professor Azazman and Professor Tasadduk in this pregnancy-related session. I would try to avoid the repetition which has already been discussed. So the roadmap would be that for the today's discussion that we are going to discuss about the magnitude of the problem, and then the pathophysiological mechanisms, and then how to detect these cases and risk stratification, and finally discussing the management paradigms and then future directions. So this is just a repetition of preeclampsia signs, that when a woman who is pregnant is having sudden weight gain, swelling in the legs, or there is trouble in breathing and suddenly do not feel well, we should check blood pressure and then do the workup further. So this preeclampsia, it resonates even after the pregnancy is finished. And what we see is that around 50% of the preeclamptic women, they develop hypertension or some kind of renal dysfunction within 1 year. And if we talk about the long-term risk, we see that 20% of them developed CKD with 4 to 8 times more risk of increased renal failure. And along with that, there is 2 to 4 times more risk of ischemic heart disease, stroke, and heart failure. So basically, this postpartum period is a critical window for the intervention as a nephrologist. So if we just see here that the kidney vulnerability and placental dysfunction, they are, it leads to a vicious circle that if a patient is having CKD prior to the pregnancy, there is reduced renal failure, there is reduced renal reserve, which leads to epithelial dysfunction and eventually to the factors leading to the abnormal placentation. So if patient, and then in the other case, if patient is having preeclampsia, there will be syncytial trophoblastic stress, and then the imbalance in anti-angiogenic factors between anti-angiogenic and pro-angiogenic factors, which will lead to systemic endothelial damage and glomerular endotheliosis, and may lead to the permanent kidney injury. So the key pathogenic mediator is the angiogenic imbalance. On one side, SFLTs, which are secreted by the stressed and distressed placenta, they are the central offenders which are leading to the glomerular endotheliosis. And they lead to the suppression and neutralizes vascular endothelial growth factors as well as placenta-induced growth factors. So these growth factors are pivotal for the placental as well as kidney health. And when these SFLTs, they are in excess, they will suppress both of them, and this will lead to the kidney as well as the placental damage. And these lesions, which are glomerular endotheliosis, swollen endothelial cells, loss of fenestrae, and eventually this leads to the proteinuria. As already mentioned by Professor Azazman Sahib, that we have to keep an eye on the SFLT and PI-GF ratio. This is very pivotal and a diagnostic as well as a prognostic marker for the prediction of preeclampsia. So again, in presence of genetic predisposition and oxidative stress, the natural killer cells, they activate, they come into action, and then their effect on placenta leads to the disturbed ratio with increased SFLTs and decreased placental-induced growth factors, which will eventually lead to hypertension, proteinuria, cerebral edema, liver dysfunction, and intrauterine growth retardation. So these are the studies in prognosis study. They have seen that if this ratio is 38 or lower, then the risk of not developing preeclampsia is around 99.3%, while if the ratio is above 38, then the risk of developing preeclampsia is higher. In other studies also it was proven that if this ratio is more than 40, then again there is a high risk of developing preeclampsia. So kidneys and preeclampsia, they are both vulnerable to the endothelial dysfunction. They share hands in it, that their pathophysiological mechanisms, they are almost the same, and they are very sensitive about the endothelial health, their dysregulated RAS system, and they are very responsive regarding the injury if there is oxidative stress and inflammation. So what we see is that once there is preeclampsia, and there's a lifelong risk trajectory as well, and the renal effect in the offspring are also seen with low nephron mass leading to oligomeganephronia, and the consequences are that there's a high lifetime risk of hypertension, CKD, and metabolic syndrome in the child. This creates an intergeneration cycle of disease as well. So as nephrologists, once we break this cycle, we can see that we can protect the next generations from the effect of CKD and metabolic syndrome. So even the American Heart Association, they have also, put stress on the UACR as a specialized test, as it's a window of opportunity to diagnose the heart disease. So we have different tools like Prevent Calculator. It estimates a 10 to 30-year risk for heart failure and stroke, and outcomes are highly relevant to the post-preeclampsia patients. This is because it directly inculcates and inputs the renal feedback mechanisms like eGFR and urine albumin to creatinine ratio. So we can predict the outcome in preeclamptic women who have a history of preeclampsia and their long-term risk of developing atherosclerotic disease as well as their post-renal failure complications. So this is the Prevent Calculator, in which there are different variables like smoking status, age, sex, total cholesterol, dyslipidemias, BMI, and then eGFR, diabetic status, antihypertensive medicines. So once we put in all the variables, we can get the results and we can calculate the risk stratification. So again, in preeclamptic women, they are not immune to other causes of resistant hypertension, because sometimes we keep on putting stress on the preeclampsia and hypertension, and blood pressure is still uncontrolled. So we should go for the other screenings as well, like focus on aldosterone, and other workup for autoimmune workup should be done as well. So managing these patients with CKD and hypertension, first of all, we should discuss the risks of pregnancy and outcomes of pregnancy, and then optimize the blood pressure to less than 130/80, switch them to safe medications like labetalol, nifedipine, and methyl-dopa, low-dose aspirin, and we should avoid ACE inhibitor, herbs, MRAs, and direct renin inhibitors. The previous policy of 6 weeks OBS checkup and used to be a discharge point. The proposed nephrology pathway right now is that 3 to 6 months postpartum formal renal assessment with BP, with blood pressure monitoring, creatinine, UACR, and electrolytes should be done. And annually forever, blood pressure, UACR, and metabolic panel should be done in these patients, and diagnose and treat incipient CKD or hypertension early, so that there can be early intervention as well. So the pharmacotherapy, if the patient is breastfeeding, then labetalol and nifedipine. After lactation, other RAS inhibitors can be introduced for their anti-proteinuric effect. And for persistent albuminuria or declining GFR, we may consider SGLT2 for the robust cardiorenal benefits regardless of their diabetic status. So there is another thing which I would like to stress upon, is that there is a genetic link to the preeclamptic outcomes, and the POL1 gene is a very high risk gene, and their variants like G1 and G2, they increase risk of hypertension attributed CKD, FSGS, and preeclampsia. And the mice model have shown that once we inhibit this disease and modify this gene, there is a decrease in hypertension, proteinuria, and fetal growth restriction. So again, this gene can be inhibited with inaxaplin, which is again right now it is under trials, and in transgenic mouse models it completely abolished the systolic blood pressure, proteinuria, glomerular injury, and fetal growth retardation. So the future represents that once the human trials are completed with this medicine, we may see that we can deal with these preeclamptic patients in a more appropriate way. So again, the kidney and the preeclamptic patients. They have SFLTs and their ratio, which is more important for their workup. But once the patient delivers, we are looking for the other markers like heparan sulfate, troponin T, and immune activation systems. And this may give us a metabolic panel by which we can predict the patients who will develop preeclampsia eventually. And there is also a promise of MMP inhibition. This is overexpression of matrix metalloproteinases in preeclampsia, which contributes to vascular remodeling dysfunction. And this is in early phase exploration. So a multi-marker panel may be made and may be, chosen once we reach the proper conclusions. So what we still need to know is that the exact molecular signal from a stressed kidney that impairs placentation, and how can we reliably, quantify the renal function reserve, and do SGLT2 inhibitors and GLP-1s have a role in modifying long-term risk post-preeclampsia, and what is optimal screening protocol and frequency of CKD after hypertensive-related disease. And regarding the nephrology community, we have to inform OBS and gynae colleagues about long-term risks and establish formal referral pathways. We need to establish preeclampsia clinics or dedicated follow-up protocols within our practices, and need clinical research targeting this high-risk population, and educate women with a hypertensive disease of pregnancy about their kidney health and need lifelong monitoring. So preeclampsia is a renal and vascular syndrome, and it begins and ends with endothelial and glomerular health. Pregnancy is a stress test and a diagnostic window. It reveals future cardiorenal risk years before traditional markers will come up. And the nephrologist is the central physician for long-term risk mitigation for preconception counseling to lifelong CKD management. And we have to screen with the urinary albumin to creatinine ratio, stratify with prevent calculator, follow for life after a hypertensive pregnancy, aggressively treat with RAS and SGLT2 when indicated, and watch the POL and targeted therapy space, and bridge the gap between obstetrics and nephrology. Thank you.
Because of the constraint of time, there's no question. Then we have the last speaker.
Thank you, sir, for reframing our approach beyond numbers to mechanisms. Now, towards the concluding, I will now invite Professor Rubina Naqvi to have a talk on pregnancy-related acute kidney injury, volume contribution to CKD, and need for lifelong renal replacement therapy.
Thank you for giving me this opportunity to speak from this forum, and I congratulate Professor Zahid Nabi and his team for organizing such a successful conference here. So after pregnancy in CKD and in dialysis patients and transplant patients, now we move on to those who develop kidney injury in relation to pregnancy. So I work at SIUT since September 1989. So I would like to share our experience of this particular subject. SIUT, as most of us, most of the people in audience, they know that it is the largest nephrology care which provide free renal services to all the patients once they register till they exist. So for the same reason, people from all over the country, not from all over the country, but the neighboring country, Afghanistan, come for the treatment to SIUT. So I'll present the data, which is from January 1990 to December 24, that is a span of 35 years. And this includes all women with previously normal renal functions, and the immediate postpartum period, they come with recent rise in serum creatinine with or without decline in urine output, and normal sized kidneys on ultrasonography. So because KDIGO guidelines were set up after 2012, if we see in retrospect, many of these patients, they will fall in stage 3 of KDIGO guidelines. But some of the patients from the same hospital, civil hospital, Karachi OBGYN unit, we can receive them in stage 1 or 2. We excluded all acute and chronic and those with long-standing diabetes or hypertension and those with normal-sized kidney and systemic disease and biopsy-proven amyloidosis. So over 35 years, 9,575 AKI patients were dealt at SIUT. And if we divide them in different groups, our topic of interest for today, the pregnancy-related AKI was contributing about 1/4 to the population, 24%. So all of them were, obviously they were in reproductive age, so all of them were young. And we divided here in different time periods so that we can compare if there is a change in pattern in these population. So 10 years, 10 years, 5 years, and 10 years. And total 2,275 pregnancy-related AKI were dealt. So as you can see here that initial 10 years, the septic abortions were higher in percentage, 14% of the obstetrical patients. That gradually decreased to 3.3 over last 10 years. And we have seen a rise in hemolytic uremic syndrome, which were rare in initial 10 years period. And it gradually increases, and we have seen markedly rise in the number over last 10 years. For all these other situations, I have not given the percentages in parentheses for the reason because many of the women, they have combination of the insults, like one with preeclampsia develops abrasio, placenta, APH, and death, intrauterine death of the fetus, and end up in emergency LSES. So this total number will exceed to the number given here. That's why I have not given percentages here. So outcome in this population over different periods, like complete recovery of renal function, partial recovery, which was about CKD stage 2 or 3, end stage who remain dialysis dependent, and those who died during acute phase of illness. And percentages are given in parentheses. We were finding about 40 to 43% in initial years, they were getting complete recovery. But here we see some drop in acute recovery, and till here, 25 years data has already been published here, but this with the red is unpublished data. And during last 10 years, we have seen less patients recovered normal renal functions, but at the same time, with the expansion of services and increasing in the number of the patients, what we find that many of the patients, they did not turn up for follow-up after the first discharge. Even some of them were showing the improving trends, but we cannot say that whether they completely recovered or not. So this reflects here a decrease in the number of complete recovery. So acute cortical necrosis was reported on ultrasound in 542 patients, and it was suspected with the hypoechoic rim under the renal capsule. whereas histological evidence of acute cortical necrosis was in 243 women, and these were not all, excluding these 542, but some in the later 10 years period when we were having more hemolytic uremic syndrome, we started doing biopsy in some, in those patients who already had findings of ACN on ultrasound. Because some patients with ACN on ultrasound were showing hemolytic uremic syndrome, and they were responding to the treatment with plasmapheresis, which we have already published somewhere. Extensive blood loss around childbirth, especially when further complicated with intrauterine death of the fetus, plus minus sepsis, remained the main cause for acute cortical necrosis. And interesting thing is that those who were labeled as acute cortical necrosis and where we think that they will never recover, 2.6% of these patients showed up with complete recovery in long-term follow-up, while another 38% remained dialysis-free in long-term follow-up. So talking about the mortality predictors in this population, all these young patients, I think pointer is not working. Okay. This one. About 98% were either oliguric or onuric on presentation. This is those 247 patients who died during acute phase of illness. And marked hyperkalemia was in 40%. Deranged coagulation was in 48%. Abnormal platelet count in either direction were another 79%. Abnormal liver function in 69%, and respiratory failure in 47% of those patients who died during acute phase of illness. CKD, which in different time periods were 21 to 53%. Some of these patients are still coming for follow-up, but we cannot provide stage-wise data in all of these patients. End stage, which was 14 to 30% over different time periods, in total numbers were 1,440 patients who end up in end-stage renal failure requiring lifelong renal replacement. So many of these patients, they died at variable time duration on dialysis. And if we talk about transplant at SIUT, so far we have transplanted 7,700 patients, 1,597 were females, and among these 68 had end stage after the complicated obstetrics. So only 4.7% of those who developed end stage after pregnancy-related AKI proceeded for transplant. So this problem that pregnancy-related AKI is seen more commonly in our part of the world, and the developed world has very little number. And we all know that AKI is a preventable, treatable, and a reversible phenomena. From the developed countries, it's a rare, and it is reported as 1 to 2.8% here in this study. And mainly it is because of preeclampsia or HELP syndrome. So how can we bridge the gap in the causes and outcomes of the pregnancy-related AKI between the developing and developed world? It requires a multifaceted approach focused on Number one, the prevention, which starts from the antenatal period to the perinatal management, and improving the healthcare infrastructure where basic health workers should be trained at basic health units to assess. They can even do the domestic and check the blood pressure and look for anemia, and they can timely refer to appropriate centers where these women can be dealt with. Early detection, for early detection, some work has been done on urinary and serum biomarkers. We have also done, and I will show you in a while, our results. And then comes the education, so I will touch a little upon the methods for education we can use. For early detection, serum and urinary biomarkers, we did this study in collaboration with the OBGYN of Civil Hospital Karachi. And we selected the women who brought up to the emergency of OBGYN CHK with the diagnosis of hemorrhage, whether it is antepartum or postpartum, or hypertension, whether preeclampsia or eclampsia, and sepsis. So as we thought that these are the women who are at risk of developing acute kidney injury, so we selected them and we did biomarkers on these patients. And these are just operational definitions for the conditions we have selected for. And the biomarkers we did, urinary biomarkers for cystatin C, NGAL, KIM1, IL-18, and serum cystatin C, which was done on time 0. And these urinary samples were also collected at time 0, at the time when they arrived at emergency with this history. So, serum creatinine, urine output were checked at time 0, 24 hours, and 48 hours. And for statistics, in order to detect area under the curve for receiver operating curves with power of 80% and 95% confidence interval, we found that a total of 97 patients will be required for the study. So during 9-month study, we found 149 risk patients. Among them, 26 developed AKI, and 123, they did not develop AKI. And these markers, as you can see, that serum cystatin C, urinary cystatin C, urinary NGAL, they show significant findings in the AKI population, whereas we did not find any significant difference in urinary IL-18 or urinary KIM1. This was slightly different from others we have found in literature. Coming to the education, this chart I have taken from this article, and they gives the 5R strategy for educating caregivers in AKI, and this was designed for NHS. And these 5 R's are, the first R is for risk assessment, which gives susceptibility, surveillance, and primary prevention. Susceptibility, like genetic or clinical risk factors, for surveillance, e-alerts, drug dose monitoring, primary prevention, high-risk patients and situations. Then second R is for recognition. The diagnosis is functional, that is urine output or with biomarkers, then staging. And third R is for response. The reversible factors should be corrected, like volume replacements, relieving the obstruction and removing the nephrotoxic medications. And for avoiding the further nephrotoxic agents, then the timely referral to the nephrology services, and then the therapy. Next R is for support. The dialysis modalities, what should be the dosing, duration, and timing. And then the rehabilitation, which is very important, the follow-up, the team approach, primary care or a specialist, and the recovery, the targeted interventions. For example, if hypertension persists, then the management of the hypertension and the functional assessment for quality of life. The same article then shows that was for NHS but can be applied anywhere, and this is a global agenda to raise awareness and improve patient care. So it all comes in the education, the 5 R's which I have just bring here, and the research agenda that we should do the epidemiological studies on outcome and comparative effectiveness, the prevention studies and the treatment studies and audits. Then the funding strategies like governmental or non-governmental organization or international organizations, they fund for these educational parameters. Then development of a toolkit for AKI, essential toolkit for recognition and management, emphasis on early recognition, utilize the KDIGO guidelines on diagnosis and management so that similar incidences and prevalences can be reported from all over, identify the knowledge gaps and educate, appropriate to reach the region, and community versus hospital acquired, because we have different causes among the developed and developing world, among community and hospital acquired causes. Then the culturally sensitive things should also be considered during the education, and avoidance of the problems for discrimination by income, gender, or religion, appropriate for the resource available. So in World Congress of Nephrology in 2015, there was a slogan that Zero by 25 initiative, and they say that nobody should die because of preventable and treatable AKI by 2025. And we have already entered in 2026, and we are still discussing these preventable causes here. Obstetrical issues are the conditions where AKI, if addressed timely and properly, they should not exceed beyond stage 1 of KDIGO criteria of diagnosis. Avoiding use of nephrotoxins and thus halting the secondary insults, because there are many nephrotoxic agents, or even if those which are less nephrotoxic, their dose are not adjusted during the phase of AKI, and they add to the existing insult there and delay the recovery. CKI is a burden on the health budget and economy, and especially in country like ours, there are very few centers which provide free dialysis or renal health. So it's self-financing is very problematic in this country. Regular follow-up of CKD stages 1 to 4 patients and monitoring their BP, blood pressure, and explaining the use of analgesics and other nephrotoxin and over-the-counter medicines is need of the time. And end-stage patients should be encouraged and properly guided for renal transplant, because as you have seen that very few patients got renal transplant done, and many of them, they died on dialysis at variable time periods. So I would like to thank again the Pakistan Society of Nephrology, our record system staff at SIUT, my colleagues who helped in management, and some they also assisted in retrieval of the data, and all those patients whose information shared here. And thank you for your concentration here.
Presenters were excellent. They made a very thorough review of the literature, and this concludes the scientific program of 2026 Pakistan Society of Nephrology. And I want to thank each and every one of you for staying to the end, and this was a very unusual thing that has happened, at least in my experience, for the last many, many years. And I congratulate Professor Zahid Nabi, his team, Professor Sajid Abbasi, for conducting such a wonderful, extraordinary conference. May God bless you all. Thank you very much again.
Thank you very much, respected panelists. I will now invite Brigadier Dr. Noman and Dr. Nayyar Mahmood to present shields to our respectable speakers. I will now invite Professor Madam Iftikhar Ejaz on stage to receive her shield. Professor Azaz Man. Dr. Muhammad Tasadduq Khan. Professor Zahid Rafiq. Professor Rubina Naqvi. Thank you, sir. You may now take your seats. Thank you, respected chair and co-chair. You may also resume your seats. I am now announcing general body meeting of PSN. So all PSN members are needed to be in this hall so that they can discuss few issues related to PCN. And this meeting will be followed by closing ceremony, lucky draws, and OCC MOU. Thank you.
आई जान कहते हैं ना क्या आई कोई आई होता है आई होता है
Bismillah ar-Rahman ar-Rahim. We are going to have a membership meeting of Pakistan Society of Nephrology, and I will request only the members to be present. The rest will be called after the meeting is over. Thank you very much.
May I have your attention, please? I will request Professor Dr. Sajid Abbasi to please come on the stage.
Bismillah ar-Rahman ar-Rahim. Thank you very much, and good evening, everyone. I would like to say here that basically the meeting points of the last ECC meeting, the key decisions which were taken. The first point is the composition of the executive committee. The decision is the executive committee shall consist of 19 members, and it would be as follows: the president, vice president, general secretary, 1 treasurer, and 6 members, which would be from the Punjab, 4 from the central Punjab, 2 from the south Punjab, and 4 members from Sindh, 2 members from Khyber Pakhtunkhwa, 2 members from Balochistan, and 1 member from federal area, which would be including Islamabad, Gilgit, and Kashmir. And second, this was point, actually, there was no policy previously for the vice president. So for the vice president, the policy has been defined, and this would be the ECC has decided that next time the ECC has decided from the next tenure onwards, the vice president shall be elected from the previous region. Third, the voting method. So it should be very clear that all members shall cast their votes through online voting only. And the fourth one is, that's important, that the lifetime membership. The lifetime membership has been abolished as already decided in 2024. Clause 1A has been removed from PSN bylaws. All PSN members must pay an annual membership fee of Rs 5,000 to keep their membership active. The policy is applicable to all members without exception. And the fifth one is the PSN registry. The PSN registry process is ongoing. All institutions will become part of the registry. This initiative will also help generate funds for PSN registry. And sixth is patron-in-chief. I think maybe some of the people don't know that Professor Dr. Sami J. Khan has been appointed as a patron-in-chief of PSN. Thank you very much. So now I would call Professor Dr. Abdul Halim. He is the Chief Election Commissioner of PSN. He was appointed and he will basically announce the election results of PSN 2026. Thank you very much.
Bismillahir Rahmanir Rahim. First of all, I am thankful to Dr. Zahid, Sajid for excellent, more than many times more than beyond our expectation, successful conference. So congratulations both of you. Now it's the final stage. So election results, and please when I take the name, they should come here, please, because the next agenda will be oath-taking ceremony. New Executive Committee election result. Professor Dr. Amr Azhar, President. Dr. Ali Saklan Haider, Vice President. Dr. Ahmed Zeib, General Secretary. Professor Dr. Ali Asghar Lainwala, Treasurer. Dr. Ahad Qayyum, Member Executive Committee. चलो ठीक, उनको ऐसे बुला लें क्योंकि फिर ओथ में होना लाजमी है, ओथ में होना सब इकट्ठे करेंगे ओथ, नहीं ओथ लेनी पड़ेगी उनको, फिर कोई और टाइम कर लें या आप ले लें एज प्रेसिडेंट, फिर उनसे ओथ ले लें, ये नेक्स्ट पॉसिबिलिटी, ठीक। डॉक्टर हाफिज बिलाल रसूल, मेंबर एग्जीक्यूटिव कमेटी। डॉक्टर गुलाम अब्बास, Member Executive Committee. Dr. Suhail Iqbal Malik, Member Executive Committee. Dr. Muhammad Wasif Beg, Member Executive Committee. Dr. Puran Mal. Dr. Aisha Ejaz. Dr. Faiza Saeed. Dr. M. Tasadduq Khan. Dr. Amal Khan. Dr. Aisha Barki. उषा बर्की, बर्की काफी परमानेंट है, बर्की उषा। डॉक्टर फजल मोहम्मद, आगे डॉक्टर हबीबुल्ला रिंद। डॉक्टर एम साजिद रफीक अब्बासी, ये कौन है? नहीं, 2 ही पेपर है मेरे पास, और एक मेरे पास भी होना चाहिए कि नहीं? मैं ज़ुबानी तो नहीं बोल सकता. Samiche Khan, with your permission, can we start the proceeding of oath? अच्छा, इसमें यह है कि जी आपके पास नहीं है पेपर? नहीं, सारे हैं. डॉक्टर अहद कयूम. अच्छा, ये डॉक्टर इबादुर रहमान, एग्जीक्यूटिव कमेटी, प्लीज. सॉरी. अच्छा, मैं थोड़ा सा ब्रीफ कर दूं आपको. थोड़ा सा आप पीछे हो जाए, ज़रा थोड़ा पीछे हो जाएंगे सब दिख. हाँ. अच्छा, ये आप सबके पास है ये ओथ? नहीं, आपको मिल जाएगी, मेरे पास एक ही है. साजिद, ये एक या 2 मिल के कर लें. हाँ, एक चीज़ इसमें सिर्फ मैं आपको बता दूं, आएगा ना लफ्ज़ सॉल्व मी स्वेयर दैट आई के बाद हर कोई अपना नाम लेगा. ठीक है जी. इधर गैप होना चाहिए था, गैप नहीं है, लेकिन आई सॉल्व मी स्वेयर दैट मैं ज़रा गैप दूंगा, आप अपना अपना नाम बोलेंगे. ठीक है जी. बाकी बस ये जो लिखा हुआ है पढ़ना है आपने, आपके सामने है जी. नहीं, वो उधर हैं, वो उधर उसमें है ना, वो प्रेसिडेंट ले लेंगे उनसे ओथ, फिर यही हाल है. कैन वी स्टार्ट नाउ? Bismillahir-Rahmanir-Rahim. Pakistan Society of Nephrology oath. Now you will follow whatever I say, except after you will take your own names. I solemnly swear that I will faithfully and diligently perform the duties of Pakistan Society of Nephrology in accordance with its constitution, bylaws, and codes of ethics. I will uphold the highest standard of professionalism, integrity, and service in the practice of medicine. I will strive to advance the interests and objective of PSN and its members, and to promote health and well-being of the public. I will respect the rights and dignity of my fellow officers, members, colleagues, and patients. I will support and cooperate with other related organizations in pursuing our common goals. So help me God. Thank you जी. आप कुछ कहना चाहते हैं? Welcome. So from right now, you are next. आप जाने, PSN जाने,
दफा करो मेरा पैसे हैं तो दे देंगे क्या कर सकते हैं घर निकाल तो सकते हैं इस मोमेंट पे कैसे चेंज होगा कुछ नहीं हो सकता I'll request all the delegates to please take their seats because we are just going to start the concluding ceremony. आप सिर्फ कंपनीज के लगे उनको बुला ले जो है ये इसके टेबल लगवाओ ना टेबल लगवाओ ना There are a few more things which we have to finalize before we depart. One is, as I mentioned in the initial speech, and that OCC, which was our partner during this conference, they have officially become our digital media partner for the next 2 years. And obviously, we will brief Dr. Amir later on what they have actually opted to do for us. And this whole conference has already been recorded. It will be available on the YouTube. Already it was running live. There was live streaming as well. So there is a small MOU ceremony signing the contract with the OCC Pharma. And 2 pharmaceutical companies they have requested. So I said, no problem. They have done some lucky draw at their center. RG Pharma, if they can come forward, please, for their lucky draw. And there was some other company, I forgot their names, they also requested for it. OCC, yeah. OCC and RG, probably they have asked for 1 or 2 minutes if they can run their lucky draw here. So I hope they are around. एक या 2 हैं? So there are 3 lucky draws. Thank you. I don't know from where they got the idea that there has to be a cutlery set. So anyway, that is the cutlery set. I don't know. So since it is a cutlery set, so I will request Dr. Talia to please come on the stage and run this lucky draw. उधर रखें उधर. So let us see who is going to get this lucky draw winner. Dr. Rashid. No, you are not the one from Karachi. But anyway, अगर वो नहीं है तो आप उनको deliver कर देंगे. So, हाँ? नहीं, next तो अभी चलेंगे लोग, शाम तक होता रहेगा फिर. चलें एक और निकाल दें. बस एक और, because otherwise it will be difficult. सब लोग बैठे हुए. So this name is probably not. उन्होंने डॉक्टरी ज़ुबान में नाम लिखा है सो even we cannot read. Dr. Bilal Mahmood Mughal from Islamabad. Yep. So he's here. Cutlery set कहाँ है? But you are the winner. You can come on the stage.
तीन चार डिफरेंट चीजें हैं वो जिसके जो
कुछ और भी है?
हाँ ये तीन है ना मुख्तलिफ
अच्छा तीन. So there is another one. Dr. Humaira. From Peshawar. वो है. और भी है कुछ?
हाँ एक और
लेकिन ये है क्या?
मुख्तलिफ चीजें हैं
तुम कह रहे हो कटलरी सेट?
नहीं नहीं वो नहीं है एक कटलरी सेट है एक डिफरेंट सेट है दो क्या नहीं ये एक और चीज़ है अब पता नहीं क्या चीज़ है
This is the final one. Razia Batul, Lahore. I think she's the... बस आपका खत्म उठाओ. So I will request now OCC Pharma if where is their lucky draw? It seems they have some good things. I don't know. Phone शोन लग रहे हैं मुझे तो. Phone है? काफी सारे. जब आओगे तो उस वक्त साथ लाना. मैंने निकाला. Oh, Professor Noman Tarif. हाँ सर को देना है कि हाँ
आप डिसाइड करें
सर आप बताइए सर प्रेसिडेंट साहब नए सर सर अलीम नोमान तारीफ साहब का मोबाइल निकला है सर देना है उनको या किसी और को दे दें जी सर नहीं वो है नहीं है यहाँ है नहीं है नहीं सर ये हमने वैसे रूल रखा हुआ था जो नहीं है उसको नहीं मिलेगा फिर नहीं देते How come? Uman Farooq. उमान फारूक इसका पहले नहीं निकला एक है वो तू क्या पढ़ के आया आज आ जाओ एक नाम अभी इसने लिया दूसरे हॉल में यही था ना यू आर वेरी लकी उमान फारूक ही है यार तुम निकाल के दो डॉक्टर खदीजा
Hyderabad. She's around? Not around. Dr. Tahir Rashid, RMI Peshawar. नहीं बस यार ये आखिरी कितने रह गए डॉक्टर एमिल खान पेशावर डॉक्टर बिलाल ताहिर बहरिया हॉस्पिटल लाहौर बहरिया ऑर्चर्ड चले गए डॉक्टर खावर सुल्तान पिम्स मर गया बेचारा Sorry, unreadable again. Oof, मैं बच गया. Dr. Zahid, but from PF Hospital. अपनी किस्मत नहीं है सर. हाँ बस ये था सर. चल यार. कल निकला था. कहाँ पे? नहीं मिला. हाँ कह रहे कल भी निकला था पर दूसरी तरफ था मिला नहीं तो आज मिल गया लास्ट वन I know he's left Dr. Shafiq Chima so he left already this is amazing Raja Rashid इसका नाम पहले भी निकला था लेकिन वो दूसरा था कंग्रेचुलेशंस जी we'll just take 1 minute for an MOU signing ceremony and then we will there'll be a vote of thanks so I would request all of you to please be seated for just bear with me for 3-4 minutes more कौन करेगा साइन तुम्हारा किधर है So I'll request Mr. Taimur from OCC Pharma to please come on the stage and Sohail as well.
Now, as we move toward conclusion, we reflect on a day marked by meaningful discussion, shared experiences, and collective learning. Thank you all respectable guests for sharing your thoughts and experiences. I will now request President PSN Dr. Zahid Nabi to present shields to the pharmaceutical companies who have sponsored us and made this event to happen.
I must say thank you to all of you, especially who came from Pakistan, from abroad, everyone. It was never possible without you all. And I feel that we tried our best to have a wonderful environment, and we all enjoyed, we learned a lot. I'm especially thankful to all the pharma support, and it was never possible without their support. So this is the time that we should appreciate our sponsors. So I'll request now Dr. Hira to please call them on stage. There is a platinum category as well, those who have supported us the maximum, so we'll call them first and then gradually the rest of them.
Thank you, sir. I will first invite the platinum sponsor company Hiranis, and the representative is Mr. Rashid. Please come forward, sir. Next is Getz Pharma, Ms. Nabiha and Mr. Ehsan. Next, Hilton Pharma, Mr. Ilyas. CCL Pharma, Mr. Khalid. Nabi Qasim Pharma, Mr. Owen Muhammad. RG Pharma, Mr. Saeed. All Med Pharma, Mr. Kamran. Ferozan Labs, Mr. Abdul Rahman. Martin Dow, Mr. Ejaz.
Now I'll request Professor Samir Khan, if you can, sir, kindly come on the stage to distribute these shields.
RG Pharma. Next, All Med. All Med Pharma, Mr. Kamran. Ferozan Labs, Abdul Rahman. Martin Dow, Mr. Ejaz. Mactor Pharma, Mr. Sajjad. ठीक है, इसके बाद कर दो ना.
I'll request Professor Sajid Abbasi, if he's around, if he can come on the stage for shield distribution.
Esther Pharma, Mr. Harris. नहीं अभी नहीं बोला HSC उसके बाद HSC Pharma, Mr. Faisal. Alliance Pharma, Mr. Saqib. OCC Pharma, Mr. Taimur.
One announcement, because I just came to know that we all are struggling for ATG, so हमें मिलती नहीं थी. So luckily now with the name of T Globulin Alliance Pharma की, it is available now and it is quite cheap, so it's a good news for all of those who are just struggling to get ATG. The other thing is that probably sustained release TAC is also available. So it is also available, so there are 2 new additions in the transplant medication. कितने रह गए?
OCC Pharma, Mr. Taimur. Reni Pharma, Mr. Amir Hassan. Platinum Pharma, Mr. Ghulam Abbas. Bionics Pharma, Mr. Sajjad.
Now I'll request Brigadier Halim, if you can, sir, kindly come on the stage so that we can continue this shield distribution. Thank you very much, Dr. Professor Sajid Abbasi.
Sir, भी हैं 9. Gentex Pharma, Mr. Ishtiyaq. B-Braun Pharma, Mr. Zafar. Otsuka Pharma, Mr. Atif. Edco Pharma, Mr. Arif. Nipro Pharma, Mr. Aleem.
I'll request now Dr. Humayun Rashid to please come on the stage to continue shield distribution, and I thank Professor Brigadier Halim.
Medisol Pharma, Mr. Iftikhar. Tabros. जी सर 2-3 और ये भी है एक. Tabros Pharma, Mr. Adil. उसके बाद Crystolite Pharma, Mr. Wakar. Mr. Wakar. सर ये भी ये लास्ट है. OBS Pharma, Mr. Imran. ये लास्ट शील्ड है, उसके बाद ये क्वांटम इवेंट्स वालों का इतना.
आप लोगों के नाम क्या है?
सर वो ये सर.
कौन से?
ये वाले डॉक्टर आहत, ये सारे ऑर्गेनाइजेशन.
Now I will request, I think this is the last farmer. Now I will request the actual team who made this conference possible. So I'll request Professor Sajid Rafiq, if he's around, to come on the stage. Dr. Humayun Rashid, Dr. Talia Tahir, Dr. Raja Rashid, Dr. Noshin Anjum. Stage पे हैं क्या कर रहे हैं? ओ चलो ना उधर चलो. Dr. Raja Rashid, Dr. Noshin Anjum, Dr. Bilawal Abbas, Dr. Zahidul Zahideen, Dr. Mafaza, Dr. Hajra, Dr. Ikra, Dr. Namra, if they are around. ये कौन है? Dr. Hira Javed, Dr. Amara Javed, Dr. Hifza, Dr. Hina. और कौन है? आ गई ना. And I'll request Professor Sami J. Khan and Brigadier Halim. We bothered them a lot while we were preparing for this conference. If they can come on the stage as well, sir. Professor, and it was never possible without all this team. And they did a lot of effort, lot of good effort. They have their shields here as well. So I will just give one shield, so just to save time, and सारे अपनी समझें इसको. Now two more shields, and these are, I'll request sir, एक second sir, this is very important. One is our event manager, Mr. Atif. He was day and night busy in preparing this conference with me. And other is Mr. Uzair Ahmed. I was just calling him right and left, up and down, day and night. So he did a lot of effort as well. So I'll request Mr. Atif to please come on the stage, and I'll request Professor Sami sir, एक second दे दीजिए हमें please, and Brigadier Halim as well to please Mr. Atif from I think this is Quantum. He did a wonderful job, a wonderful job. I would request Team Quantum to please join on this stage. They did a wonderful job.
Yeah, Team Quantum.
Well done, Janab. I really appreciate it. Thank you. हम आपका शुक्रिया अदा नहीं कर सकते, लेकिन जो एफर्ट आपने किए marvelous.
And I will request Mr. Rozair, he is Secretary PSN, and he did a wonderful job as well throughout this conference, and we must appreciate his efforts. कुछ गड़बड़ भी की है वो बाद में बताऊंगा. लंच किस तरह आते लंच इधर लंच ठीक है. So with this we conclude thank you very much. With this we conclude. The lunch is ready for the faculty on the right side, and rest is in the Angan. Thank you very much. Khuda Hafiz, Allah Hafiz. Sajid wants to say something.
So I want to announce NephroCon 2027. So I think I would like to see everyone in Murray and May or April 2027, hopefully. Thank you very much.